Assalamu alaikum and good morning, everyone. We are ready to start the second day, first session. And I request Dr. Adnan Said to please chair this session and take the chair. Dr. Adnan Said, Head Nuclear Medicine, Oncology and Radiotherapy Institute, Nouri, Islamabad.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. Ladies and gentlemen, we start this is the third session of this workshop and the first session of today. In this session, we have 4 presentations, and this is related to SPECT-CT, ischemic heart disease, artificial intelligence, and again, diagnosis of infection. The first presentation is from Dr. Babar Imran on SPECT-CT need of the hour. Dr. Babar Imran is presently working as Director, Punjab Institute of Nuclear Medicine, Pinham, Faisalabad. He has got Tamgha Imtiaz. Basically, he is a medical doctor and has attained highest academic degree of the discipline, that is PhD in the nuclear medicine, with international postdoctoral fellowship in Japan and Italy. He has a strong research aptitude proved by high quality papers published in peer-reviewed renowned journals of high international ranking, generating significant impact factor, which is more than 150 and more than 1,000 citations. He is chief editor of European Journal of Medical Case Reports and also chief editor of Pakistan Journal of Nuclear Medicine. He is an examiner of FCPS, MSc, and PhD program, examiner of the Asian Board of the Nuclear Medicine. He is master trainer of nuclear medicine and emergency nuclear medicine at hospital and supervisor of the postgraduate trainings. He has honor of national and international prestigious awards. He was supposed to give his presentation physically in this auditorium, but due to certain reason, he met with an accident yesterday while he was coming for this workshop. By the grace of the Almighty Allah, he is alhamdulillah well, and that's why he will deliver his presentation through Zoom link. So I'll request Dr. Mohammed Babar Imran to start his presentation. Sir.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning. I hope I'm audible there. Am I audible?
Yes.
Okay, fine. Thank you. I hope weather there is also sunny like in Faisalabad. Today we'll talk something about the SPECT-CT, and this is not something very new for many of you.
Sir, आपका mic mute हो गया शायद. Spawn mute कर लीजिए. आप ठीक है.
If you look at this image, it is full of information, and we need to focus somewhere where we actually need to. There is another image, and we need some more information to interpret this image or to see what this image is made of. Now, again, coming to the first image, if we localize here as it is seen on the screen, then it would be easy for anyone what we want to see. Similarly, the other image, if we get this information, then it is easy to depict how this image was created. Now, these two information for general image, if we translate all these things to nuclear medicine images, this is what comes for SPECT-CT. So we will talk about SPECT-CT need of the day. And when we combine these two information, one from SPECT, which is functional, and one from CT, which is more anatomical or structural, then combination of these information, 1 + 1 is not exactly equal to 2. It is something more than 2. We have been registering information from different imaging modalities, either on the paper, on the screen, or in the brains of those who interpret these information. Say, for example, on papers, we can have fiducial markers on the images of two different modalities, and we can combine these two images, information from two modalities, with the use of fiducial markers, and can exactly localize where the pathology is. Like in this image, if we can see, if we just see the image on coming from the nuclear medicine, then it might not be easy to depict that both the foci are not coming or not giving information exactly of the same region, or the pathology or the lesion is exactly on the same or in the same region or the bone. Here we can see that in one image pathology is in the scaphoid, and in other one it is trapezoid. Similarly, we frequently image those cases where patient has gone through thyroid surgery and there are regenerating nodules. And if we perform thyroid scintigraphy, we just say that these are regenerating nodule. And actually this information or this diagnosis was already known to the referring physician and also to the nuclear medicine people that these are regenerating nodule. So effectively, if we are just getting scintigram, we are not giving much information to the referring physician or surgeon. But if we can transpose information on the patient photograph, then we exactly can say that which part of the regenerating nodule is having functional tissue and which part is not having the functional tissue. And this is vital information, because if functional tissue is there, uptake is there, probably this is benign. And if tissue is there and there is no function on scintigram, for example, there is no uptake of the radio tracer, and if we can depict that, if we can take that part, then it would be easy that this part might be suspicious or malignant, or we can go further investigation on that part to reach the exact diagnosis and the treatment. Now, these information were actually being gathered or taken or depicted or inferred by transposing information from one part to another part, either physically or, as I said, within our brains. Now, in the present era, it is easy to get these information from single machine and then combine them, register them, and can get better result exactly in one sitting. These are the machines which give us these kind of information. One gantry gives information about the functional status, and the second gantry gives information, which is CT, X-ray CT, gives information about the structural or morphological changes. SPECT-CT actually is hybrid imaging, which combines information from two different imaging modalities. images are actually fused and they provide both information in one go. This kind of imaging or combination of imaging, it reduces the need for any additional imaging studies and of course improves diagnostic accuracy. It also reduces the radiation exposure from multiple repeated again and again imaging, and imaging time for the patient is quite short. Now, this is another image, which is actually a slice of brain imaging. One image is from the SPECT and other one from the morphological imaging. SPECT tells us where is the deficiency, and if this was because of the focus for epilepsy, there is reduced activity. How much area is involved in this can be exactly depicted when we transpose or register these two kind of information together in one image. So in this way, it would be easy for diagnostician to give complete information to the referring physician or even to the surgeon for any kind of intervention. The concept of SPECT and CT was introduced in 1950 and 1960, and it was actually practically materialized in 80s, and then now it is available widely in the world. If we go for the literature, if we can see that hybrid imaging, just this was done from the net, it gives something like 76,000 published studies just by single key hybrid imaging. And out of that, something like 41,000 studies were on the SPECT CT. And now upcoming, it's not upcoming, it's already established theranostics. Again, it involves both information from the functional imaging and part of the information from the structural imaging. And it is still going up. Something like 24,000 studies are available, which are published on the net. Now, if you see, SPECT CT is still continuing, but it has reached a plateau. The reason is this, that most of the studies, these are now coming from the hybrid imaging, and now they don't put even hybrid imaging in the keyword because this is sort of a default part of the study which is being done for the research. Yesterday, probably you had enough lectures and exposure with the PET-CT studies. PET-CT versus SPECT-CT. Which one is better? Of course, PET-CT is better because of multiple reasons. But SPECT-CT has its own place. It has less radiation burden and of course, less financial burden as well. Initial cost as well as running cost and cost borne by the patient or cost per patient is also less compared with the PET-CT. It offers dynamic imaging and variety of radiopharmaceutical agents are available for SPECT imaging. We will discuss by the end of this presentation what SPECT-CT is doing us, what it can do for us, and what we need to do to get proper information from the SPECT-CT imaging. SPECT-CT provides in conventional nuclear medicine imaging provides information in the bone scintigraphy, lymph nodes mapping, tumor imaging, imaging for inflammation and infection, localization and imaging of parathyroid adenoma, prostate cancer, and of course, theranostics. These are just few to name. effectively, SPECT-CT provides information in almost all kind of situation in conventional nuclear medicine department, wherever, whenever there is ambiguity in the diagnosis. Now, this is one image very familiar to nuclear physicians. It's a bone scan, and it shows metastasis, cancer parts, cancer roots, or cancer spread throughout the skeleton. It's very obvious, and probably we don't need any more imaging modality to say that this is whole body metastasis. Metastases are there in all the skeleton. How about this image, especially in this region? There might be ambiguity. There might be a problem to exactly depict in the nasopharyngeal region whether this is just a normal or there is some problem in that region. But this image, most of these images are from Pinham. You can see it's there is a stamp of Pinham as well, Pinham Hospital, Faisalabad. Now, how about this image? It seems there is some problem in the upper part of chest. And probably we need some more information to clearly depict or to clearly say what it is and where it is. Here, SPECT-CT was performed just to check what it is, and actually it was the position of the spine, gibbus, which was giving increased uptake in specific region, and it was giving more counts from the posterior imaging. And of course, because of the continued stress and change in the mechanics, there was increased uptake of tracer in this region compared with the rest of the spine. So it was also shown in the anterior images. It was very much clear with the SPECT-CT that this is not pathological in a sense that patient is having some tumor or cancer, or there is no spread of cancer in this region. In that sense, this is not pathological. When there is clear-cut one lesion in a case where already patient is known having malignancy, harbor malignancy, and if there is any problem in the bone, there is one lesion, if this lesion is malignant or not. And if there are two lesions, these two separately, which one is malignant and which one is not malignant. Now, if we see the first lesion, which is the lower thoracic upper lumbar region, there is uptake of tracer in the vertebra extending to the posterior compartment as well. Concomitant information from the CT, it shows that there are changes in the body of the vertebra. So that is a coming from the metastasis. Malignancy has reached to this place. How about the second lesion? Is this also a malignant or otherwise? If we see here, this is not malignant because uptake is in the joint. So second lesion is non-malignant. The first lesion is malignant. And this information for the oncologist or for the surgeon, this is of profound importance with reference to planning for the therapy for this patient. How about this lesion marked with the arrow? Again, SPECT-CT in this case, uptake was in the spinous process, and which is probably because of the trauma. This is known case of chondrosarcoma, again from Pinham. Of course, there is uptake in the shoulder region, and that is malignant. But how about a defect in the sternum. Is it from the malignancy or otherwise? SPECT-CT with 3D reconstruction clearly showed that this was of the cleft sternum, not because of the malignant involvement. There are many published studies. One of them is prospective study with 80 subjects and 50 out of them with known carcinoma. Solitary lesions on planar scan were seen. SPECT-CT added more information and it reduced the number of false negative results and increased the number of true positive results. It also reduced number of equivocal reports because in that case, time for the final diagnosis is increased, financial burden on the patient is more, and of course, treatment is delayed. Now, coming out of the malignancy, non-malignant cases, old age, or even sometime younger age, backache. SPECT-CT contributes a lot to reach the final diagnosis. This is a case of an industrialist who was having with abdominal belt, abdominal pelvic binder. For the last 2.5 years, patient was sent for SPECT-CT to exactly know what was the diagnosis, and there was inflammation in the joint. Exactly diagnosed with the SPECT-CT. Patient was sent back with this report. Patient was put on double regime anti-inflammatory drugs, and patient was fine after 1 month. And there was no binder, and patient was very happy just with the treatment of double regime anti-inflammatory with some steroids for 1 month. Patient was fine and okay. This is from the published literature. Again, inflammation was in the joint, and it was clearly depicted with the SPECT-CT. Another patient, 68 years old, backache, and there is uptake on planar imaging in L4 and 5 region, and SPECT-CT gave us information about the source abscess, para and pre-vertebral collection, and it was of infective pathology, and exact diagnosis could be reached with the SPECT-CT. Published studies show that SPECT-CT is useful to identify the specific cause of pain in elderly patients with degenerative disease, and it helps us to provide appropriate treatment, avoiding unnecessary use of invasive spinal fusion surgery when actually it was not required. And positive bone SPECT-CT scan, they provide good predictors for post-procedural response. This is bonus case for nuclear physicians. I suppose time is 9:30. I'll just quickly review rest of the cases, rest of the slices. This is a bonus case for nuclear physicians, patient with pain in both knees. Now, additional information from the bone scan that there is something in the pelvis. Actually, this is dual renal transplant. After failure of one transplant, second transplant was done. And here it was clearly diagnosed with SPECT-CT that this is because of the avascular necrosis resulting from continuous prolonged use of steroids for renal transplant. Another case, again, a bonus with additional information, focus of uptake in the neck of femur. And this neck of femur actually is not fractured. Actually, this is a firearm injury, gunshot, and bullet is still there. You can see here. I'm not sure if I can show you here. Bullet is still here, and uptake in the neck is because of the partial injury passing by this bullet part. Again, this is a bonus case for nuclear physician, patient with bilateral amputation and increased uptake here. This is whether this is because of the malignancy, inflammation, infection, or what else. And actually, it was something else. It is calcification, heterotropic calcification in the soft tissue. SPECT-CT provides much more information compared with isolated X-ray or bone scan information. It provides correct determination from 92 to 100% of the cases with high diagnostic confidence. It can also provide that dosimetric calculation for radionuclide palliative therapy. In GI bleed cases, it provides exactly where the bleed is, and it provides this information with high diagnostic accuracy up to 75% of the cases. But we have to be vigilant for the time of the focus appearance so that we can provide proper information if we do proper SPECT-CT at a proper time. This case from Pinham, case of GI bleed, there is focus here increase, but it is something different from GI bleed. It's uptake within the vessel, whether this is outpouching or something else within the vessel aorta, which is giving a focus of increased uptake of tracer, and it was not exactly the GI bleed. So it's already known from the published studies as well that SPECT-CT in these cases provide additional information other than just localization. In case of thyroid, it provides the extent of enlarged thyroid gland goiter, and it also provides exact localization if we want to go for biopsy, where this biopsy should be directed. In post-surgery, in CA thyroid cases, presence of the foci, where these are located and what exactly the nature of that tissue is, whether this is in the bed, probably the benign tissue, or in the lymph node, or even in the bones or other metastasis. So if other areas are involved, of course, nuclear physician know that staging is changed and prognosis is changed, and we need to be more vigilant, not only for surveillance, for us also for therapy in these cases. Two foci, and one of them is in the bone, and that leads to enhancement of the staging. Two foci in the neck region might be in the thyroid, probably the residual thyroid tissue, but something else is in the abdomen, and what it is exactly, this is focus in the rib, and again that leads to increase or enhancement of the staging in this case. How about this again in the abdomen, but this is not in the rib, this is in residual activity within the kidney. What is this? Again, this is a case with the iodine 131 whole body, something there in the abdomen, and this is outpouching of the intestine. This is not malignant, this is residual activity within the lumen. Peer review literature says that overall increment in these cases is up to 75% of the cases, modification of the treatment something like very near to 50% of the cases, and it avoids unnecessary treatment in 20% of the cases. And this is very important, that we should not treat each and every case. Avoidance of treatment, because it involves not only the finances, it also involves radiation, which is quite a risky job, which is done by the oncologist and the nuclear physicians. This is data from another study which provides analysis from the concordant and discordant lesions. Again, it provides additional information when we are performing SPECT-CT. And this is very important when thyroglobulin is borderline or increasing, when activity is something like in the thymus or in the bronchitis. Precise localization is in more than 70% of cases, and decision appropriate analysis is in 36% of the cases. In case of parathyroid imaging, it is very important to localize not only the focus, but all the foci can be localized with nuclear medicine studies. Here, there are 2 foci present in the neck, which were actually treated with the surgery, and patient was relieved from symptoms. Another case, there is focus of abnormal uptake and exact localization with the SPECT-CT. SPECT-CT after first surgery, again, it helps a lot more than rest of the imaging modalities, where if any, the culprit lesion is there, it localizes precisely. In published study, out of 1,236 patients, lesion-wise analysis in hyperparathyroidism cases, also in patient-wise lesions, accuracy was something like 88%.
So
And again, peer review literature supports all these information I have shared with you. In the good old days, they have been very helpful in the diagnosis of breast cancer with scintillammography, and still in some cases we need it, and it has good sensitivity and specificity if we use SPECT-CT in these cases. And of course, in sentinel lymph node, it is very important to exactly localize, not even the first tier, even the second tier cases also. And in difficult cases, not only in breast, in other malignancies, when we want to go for sentinel lymph nodes, in difficult situation, SPECT-CT and especially 3D imaging, 3D reconstruction, it helps a lot to exactly reach where lymph node is present. This is from the published literature. SPECT-CT also helps in some of the cases in cardiology. For after attenuation correction, we can exactly tell where the lesion is, where the problem is. And also, sometime when we quantify, we can exactly tell which lesion is preferred for the intervention first, or whichever the lesion should not be touched during intervention. Now we are going for the theranostics, a case of 72 years old male, prostate cancer. And this case is imaged with technetium-based PSMA and SPECT-CT exactly localized where the lymph node is.
Dr. Babar sir,
Yeah, just a couple of slides. Another case, again done with the technetium-based PSMA. Comparison of PSMA labeled with technetium and gallium. Of course, gallium-based is more beautiful, but technetium-based is giving almost all the information. Here you can see. Here it is the tomography of both cases. And the last slide, here radiotherapy planning, SPECT-CT can add more information if IMRT is merged with the SPECT-CT imaging. SPECT-CT, it provides improved accuracy and localization, and it improves with the correction of attenuation as well. And this is beginning of an end to unclear era of nuclear medicine. We have been called as unclear medicine instead of nuclear medicine, but now it is getting towards clear medicine. And just last slide, that JNM, last September issue of JNM, out of 20 articles, none was based on the planar imaging. Almost all had hybrid imaging. So the message for nuclear physicians and nuclear medicine center managers is that we need SPECT imaging, SPECT-CT, at least one SPECT-CT, so that we can get proper information at least on one machine. And for that, we need skill, knowledge, training, and all that leads to competency. So SPECT-CT imaging instrument is necessary for all the nuclear medicine centers. At the same time, we need to enhance our competency. Thank you very much. Have a nice day. If there is any question, I'm here, but probably I have already consumed almost all the time.
Thank you very much for a very nice presentation regarding the spec CD need of the hour. Any questions or comment? Next, question आ रहा है sir.
Assalamualaikum, sir. Dr. Zahir here. Just one simple question regarding your last slide about use of SPEC CT in radiotherapy planning. Do you think that PET CT is going to be in the more forefront in this field rather than SPEC, because development of radiopharmaceuticals specifically for radiation therapy planning, I don't think so. There's much work being done in that part rather than PET CT is becoming more standard in this field. Your comments on that?
Yes, exactly. You are right. That is coming up as gold standard, but that depends how much hard work we put in. That depends how much hard work we put in. It's always there that nuclear medicine goes at forefront, and then that era or area is captured by other modalities. Example is, for example, brain imaging. We claimed in late 70s, we claimed as nuclear physicians that we can image if there is a tumor in the brain, or if there is a blood-brain barrier breach because of CVA. And then CT and then MRI came up, and then we are no more in that area, right? Similarly, we came up with the liver scan in good old days in 80s. There have been flood of liver imaging with colloids for metastasis in the liver from breast cancer. And there was always skeletal scintigraphy and liver scanning in almost all the cases with breast CA. But now there is no more liver scanning. So it depends how much hard work we put in. What I meant is that this is one of the area we can work on. We can put more efforts to bring up something which is available almost everywhere in the world. So, of course, PET-CT and other modalities are spreading, but the conventional nuclear medicine is available everywhere. If we can put more hard work, more effort, we can bring up more information for the physician. So this was the actually putting up this slide in the presentation. Thank you very much for your question and comments.
Sir, thank you very much once again for the presentation. We'll now move to the next presentation. Our next presenter is Dr. Mehdi Raza. He is a consultant in nuclear medicine, and he has a vast experience in nuclear cardiology. And presently, he is working as head of the department in the nuclear cardiology department of AFIC. And he has also worked in Army Cardiac Center, Lahore. He was graduated from Army Medical College, and later he did his MSc in nuclear medicine from Pias. And he has also been a fellow of College of Physicians Surgeons, did his FCPS, and holds a diploma in diving and underwater medicine, and also got a certificate in health professional education. He has been involved in the training of the undergraduate students and postgraduate trainees, and done his observership at Royal Melbourne Hospital, Australia, Royal Brompton Hospital, UK, and Xi'an University Hospital, France. He is supporter of knowledge and professional skills through international collaboration in research. And he has also been awarded with the Tamgha Bisalat from Government of Pakistan. Dr. Mehdi Raza will talk about the ischemic heart disease and management of the chest pain. Dr. Mehdi Raza, please.
honorable delegates, colleagues, seniors, juniors, ladies and gentlemen. Assalamu alaikum. I would first like to know how many in the crowd are medical doctors and how many are not, so that I accordingly try to tailor my presentation to your to decrease the boredom of those who would not be that interested. How many are medical doctors here, please? Can I have a show of hands? Oh, so that's quite few. Now, there are two options. In fact, my presentation is a long one, so I can cut it short. So how much time do I have? 30 minutes or 25. I'm so grateful for the introduction you gave, sir. So I think we'll head for the images rather than the discussion, because the discussion may be technical and may not be interesting for people who are not from the medical field or from nuclear medicine, and images may be interesting for everybody. We have a lot of cardiac scans here, which I would like to show to you, and maybe at the end of the presentation, or maybe in the middle of the presentation, many of you would be able to see and interpret them for yourself. Do I have your permission to proceed? Excuse me, I need your help, sir. Can we move on to the second part of the presentation straight away, rather than this? So let's start with the interesting case files from nuclear cardiology, and then if we have time, or if you are not that interested in these things, we'll go back to the technical aspect, the first part of the presentation. I hope everybody agrees with what I'm doing. Even if you don't, I have the mic right now. That's what I want. So in the first part, we will be showing you normal scans. And in the second part, we'll show you abnormal scans with the histories. These are actual cases, so you would find them interesting, perhaps. Any questions, queries are welcome, and I would not mind being stopped in the middle, because one scan, once we go through it, we'll leave the space for another scan, and we might not be able to discuss it then. Although at the end of the presentation, we can come back to any scan, you can note the case number and we can show it and discuss it. So the first patient presented with chest pain. This is a case from 2018, and his echo showed good LV and ejection fraction of 60%. ETT was borderline positive for ischemia. In past history, the patient had an anterior wall MI, and coronary angiogram showed double vessel coronary artery disease. There was total occlusion of mid-LAD and minor disease in major obtuse marginal with critical disease in distal RCA. The patient reached the cardiac center in time and had a primary percutaneous coronary intervention to LAD with a plan for PCI to RCA in a staged way. These are the unprocessed images, the cine images. These are the slices. I hope you all know how to read the slices, those from nuclear medicine here. These are the short axis slices. The stress ones are at the top and the rest ones are under them. we move from the apex towards the base. As you can see that there is no LV cavity in the earlier slices, and in the later ones you have LV cavity, but a deficient septum. And why is that deficient? As you may be knowing, the proximal septum is membranous. So you don't get uptake of the tracer as it goes to the myocytes. These are the horizontal long axis slices where we are moving from the inferior side to the anterior side. Again, the stress is at the top and rest at the bottom. And these are the vertical long axis slices where we are moving from the septal side to the lateral side. This would be the lateral wall. And again, the stress and the rest slices. In the short axis slices, typically they are donut shape. You have septum on this side, anterior wall here, inferior wall here, and the lateral wall here. When we come to the horizontal long axis, we have the septum to this side and the lateral wall to this side with the apex projected at the top. In the vertical long axis, we have the anterior wall, the apex, and the inferior wall. And when we are here, it would be the anteroseptal because we are on the septal side. And as we proceed further in the row, this would be the lateral side. So we would have the anterolateral wall here. And similarly, the inferolateral here and the inferoseptal here. This is the polar plot. You can see that these images are pretty good. There is hardly any defect visible, although the patient presented with an acute anterior MI and had a totally occluded LAD. So what happened here is that he got or she got treated in time, and we salvaged all the myocardium, and the resulting scan showed you no infarct or no defect. You can see the polar plots here, the stress and the rest. There is no reversibility of any significance. This is again that defect we were talking about, the basal septum, which is membranous. This is an enlarged view of the polar plots. You can see the perfusion is also pretty fine, percentage terms here, and the reversibility is none. This is a severity map where we have the standard deviations showing. None of the standard deviations is beyond 2. As you would be knowing, plus minus 2 standard deviations is considered to be within the normal range. There is an extremely less likelihood of something being abnormal and falling in this range of plus minus 2 standard deviations. Some scores here, you can see that they are 0. I hope it's readable. This is the sum thickness scores, myocardial thickening, some motion scores here, and these are the gated images. The wall motion is also normal. You can see the contours. The contours are moving together. There is no lag on any side. Now we come on to the abnormal scans. This patient had a history of chest pain, past history of triple vessel coronary artery disease. A percutaneous coronary intervention was done to LAD, so angioplasty to LAD was done, and coronary artery bypass grafting was also done. Echo showed mild anterolateral hypokinesia with ejection fraction of 50%, and the angiogram showed Lima to LAD, the left internal memory artery, which was grafted to the left anterior descending artery, that showed no flow with a patent stent. So again, if you look at the scan is absolutely normal. So what happened in this case? I'm showing you this case because the earlier case you saw, there was an acute anterior MI and the patient was timely taken to the cath lab and a primary angioplasty was done, and that saved the myocardium. In this case, PCI to LAD was done and cabbage was done for triple vessel coronary artery disease, but Lima, the left internal memory artery, which was grafted to the left anterior descending, failed to grow. So if there is good flow in the vessel on which the graft is placed, the graft normally does not show any flow and gradually gets occluded over time. We can see that there is no reversibility in this scan, and this is a scan which is showing you good perfusion on both stress and rest polar plots. Similarly, on the slices, the short axis, the horizontal long axis, and the vertical long axis as well. Now, this patient had chest pain on exertion. This is case number 1. It was, the echo was a normal study with EF of 60% and left anterior descending artery on coronary angiogram showed subtotal occlusion in mid-LAD followed by diffuse disease. What do you see here? Can I get some help from the audience? Who can interpret a cardiac scan well? Somebody who has a mic? Apex is lost. Good. What about the stress and the rest comparison?
There is reversible perfusion defect involving the apex and anterior wall,
Very good. And which vessel is that?
LAD.
LAD. Great. So we have an ischemia,
Ischemia involving the apex and
LAD
anterior wall.
distribution, and we had a subtotal occlusion in mid-LAD. So we were expecting that we would see something in the mid to distal territory of the LAD. So which would be closer to the apex. Case number 2, we have anterior wall MI, streptokinase was given, and coronary angiogram showed single vessel coronary artery disease, which was followed by percutaneous coronary intervention. So a drug-eluting stent was placed to mid-LAD. The echo showed normal ejection fraction of 60%, and no coronary angiography was done in the recent past before this imaging was done. The patient was referred for imaging, and what do we see here? Again, it's written. We see a similar picture. We see LAD ischemia. There is a defect on there's a defect involving the apex and the interoceptor region, and this shows reperfusion of the tracer on rest images. Case number 3, complaining of chest pain on exertion, past history of triple vessel coronary artery disease, followed by coronary artery bypass grafting, PCI to OM, obtuse marginal angioplasty with two drug-eluting stents. So it was ostial and proximal to mid, OM which was stented. Echo showed fair LV with ejection fraction of 50%. Angiogram was not done. What do we see here? I'm sorry, this mouse is not following me exactly. So which territory is this? And diagonal also. When you get bored with the cases, you can tell me, we can go to the lecture again. So chest discomfort, this case presenting with chest discomfort, case number 4, past history of triple vessel coronary artery disease, followed by cabbage, coronary artery bypass grafting, Echo is normal with ejection fraction of 60%. Coronary angiogram shows native triple vessel coronary artery disease for which the CABG was performed, patent Lima to LAD and vein graft to PDA. I hope you're familiar with all these terms. So the Lima here, the left internal memory artery, which was grafted to the left anterior descending artery, is patent, unlike the last scan we saw where it had been occluded. The vein graft to the posterior descending artery is also patent. There is a critical narrowing of the vein graft to the obtuse marginal. So what are we expecting here? We are expecting a patent Lima and vein graft to PDA. So the LAD distribution would be fine and the posterior descending artery distribution should be fine, which generally is a branch of the right coronary artery. Critical vein graft to obtuse marginal means obtuse marginal, as we know, is a branch of the circumflex normally. So we would expect something in the circumflex territory, which is generally the posterolateral wall. So here it is. Again, this is reversible. So this is circumflex territory ischemia. Case number 5, chest pain, history of percutaneous coronary intervention to LAD, mild enterolateral hypokinesia, EF of 50%, angiogram showing patent stent, but totally occluded diagonal branch, 80% stenosis in circumflex, and a normal right coronary artery. Again, what is expected here? We should have something in the diagonal territory because it's totally occluded, and we should have something in the circumflex territory, which is showing 80% ostial narrowing. So what do we see? This is the diagonal territory again, and this is the circumflex territory, all of them showing reperfusion to a significant extent. So we find this reversibility map. This area showing reversibility. Another case, chest pain on exertion, past history of triple vessel coronary artery disease and coronary artery bypass grafting. Echo was not available. Angiogram showed native triple vessel coronary artery disease for which the CABG was performed. Patent Lima to LAD and vein graft to OM and occluded vein graft to PDA. So we are expecting here something related to the PDA, related to the right coronary artery territory, the inferior wall most likely. And here we see that. Now, what do we see? We see this not reversing much, this reversing to some extent. So the PDA graft with the native PDA disease is causing this problem here. It looks like a subendocardial scar, maybe partial thickness, or maybe long-standing ischemia. It may well be hibernating myocardium here. This area, which was not visible on the angiogram as an area of concern, is showing some problem. So most likely, this is the diagonal territory for which we need to study the patient further. We all know that at times the revascularization is not complete. It is not possible to revascularize every territory. Lima may be grafted onto the LAD, but a diagonal may not be able to get flow from that Lima if it has its own disease and the Lima is not carried till the diagonal. We'll do a couple more cases and then I think I can come to my presentation. Chest pain is the complaint of this patient. There is a history of percutaneous coronary intervention to LAD, so angioplasty of the left anterior descending artery. The angiogram shows patent stent, patent LAD stent with minor in-stent restenosis. Circumflex shows critical disease, and subtotal occlusion, RCA shows mid-course critical disease. So we see problems in the RCA and circumflex territories and in the LAD territory. So maybe there is disease other than the patent stent which is deployed. There may be disease distal to the patent stent which is causing the ischemia in the apical and adjoining anteroseptal region. And circumflex and RCA, we already know, are critical, with the circumflex even being subtotally occluded. I think we can leave this case. Let's go on to, yeah. This is a case where no reversibility is seen. The patient presented with chest pain, was diagnosed as anterior wall MI. There is apical akinesia on echo with ejection fraction of 35%. Angiogram shows a totally occluded LAD from mid-course onwards, moderately diseased circumflex, and mildly diseased RCA. So moderate and mild disease in circumflex and RCA, we don't expect much lesions. We expect problems in the LAD, which is totally occluded from mid-course with a history of anterior wall MI. So we see that this particular patient is showing no reversibility in this area. So there is an apico-inferior defect, which is not reversing, which is a fixed defect. We do know that in case of the left anterior descending artery, there is a variant which is called a wrap around LAD. So it wraps around the apex and comes down and supplies the adjacent part of the inferior wall. So we don't expect the RCA to be involved here. We are just expecting the LAD, which is probably the wraparound type, which we get to know if we look at the angiogram, and which has impacted and led to an apico-inferior defect. I think because we started late, and I would like to leave some time for question answers. So you're welcome to ask any questions that you want, and I'll hold the horses here.
Thank you very much, Dr. Mehta. Just one question, or we can have some information from you regarding your experience in the nuclear cardiology in 2 cardiac centers. What is your experience, or have you done anything special regarding the scintigraphy in cases of acute chest pain? So can you share that?
Generally, it has been happening in the past. People have worked on it. There is published literature that acute cases which were brought into the emergency were injected the tracer and then imaged. So they would get to know the area under threat from the occlusion or the rupture of the plaque. Later on, once this thing evolved, nowadays the guidelines are such that anybody who comes in with chest pain and the troughs are deranged, then they take the person to the cath lab. Even if the ECG is normal and there is a clinical suspicion or the troughs are deranged, the patient will go for a primary percutaneous coronary intervention. And so those scans are no more done. But we do have acute chest pain cases which keep happening. There is an entity called ischemia with non-obstructive coronary arteries, INOCA. So there are cases who keep coming, and their angiograms or CT angiograms that are done do not show obstructive coronaries, but their symptoms are angina symptoms, and they do have angina. Such cases are well catered for through scintigraphy, as scintigraphy is able to demonstrate reversibility in such cases. And especially, we have a recent addition in our Armed Forces Institute of Cardiology and National Institute of Heart Diseases Nuclear Cardiology Department of a CZT camera. So we have the CZT camera, which can do dynamic imaging. And dynamic imaging can lead to diagnosis of small vessel coronary artery disease also, as it looks at the blood flow in patients in real time. And it also looks at the coronary flow reserve, the myocardial blood flow and the myocardial blood flow reserve in cases. So if the reserve is depleted, we do understand that there is an issue in the resting perfusion. And if the reserve is intact, then we think of other options. I hope I've answered your questions.
Thank you very much.
I just have one question. A few of the nuclear medicine physicians, yeah, only one question. They are strong proponent of the thought that if CT angiogram is available, and it should be employed instead of using a SPECT MPI, because the results are more promising. So I just wanted to know of your thoughts about it. Like I recently attended one conference where they said that in future it will phase out. SPECT MPI will not be doing that, and everyone will be opting to do CT angiogram. What are your thoughts about it, sir?
I'm sorry, I could not show my presentation. I had catered for that in the presentation, but it's an interesting question, and my observation is interesting. I don't know if Professor Al-Ghazar or Dr. Rohan will bear me out and they have similar experience. Since the time coronary CT angiogram came into practice, referrals to nuclear cardiology department have not dwindled. In fact, they have increased. Because every other day, somebody goes through the coronary CT angiogram and there is some lesion which is there, which bothers the cardiologist. They think that this is juicy, it needs to be stented. And the patient is complaining that I have these problems when I'm walking about or even at rest. So they then have to send the patient to us to determine the functional significance of the lesions that they see on the CT coronary angiogram. Those patients earlier would not have gone for a coronary angiogram because the complaints or the gravity or the risk was not to that extent. But with the advent of CT coronary angiogram, this has become very normal. Again, there are patients who have some nephrotoxic problems, some nephropathy, some hypersensitivity to the contrast, which cannot go for CT coronary angiogram. Even those patients who are anxious or have a high resting heart rate are not generally imaged through CCTA. So I would say that it has helped more the cause of myocardial perfusion imaging rather than phasing us out. And I don't feel that we'll be phased out, because even more than ischemia, we have this viability, which is so important, a study that we keep doing and helping our colleagues in cardiology and cardiac surgery with in making decisions for patient management. I hope I've answered the question.
In the cardiac field. So with that, we can also study the metabolism of the heart, which is very important, and we cannot do with the CT angio. So for the CT, we can't see those metabolic changes. So nowadays, in many centers, it's a routine practice to have the this MIPI as well as FDG together.
Thank you very much, Dr. Mehdi. And
I want to say something too.
so please.
Of course, I agree with you. I need to clarify one point. Many colleagues consider the angiogram as a gold standard, which is a big mistake. And many studies early on, they judged the myocardial perfusion accuracy based on the results of the angiogram. And this is not also accurate, because the hemodynamic changes are more important for whatever diagnosis or detection and the follow-up and the prognostic signs and all of that stuff. But so logically,
there are cellular and some subcellular changes, as well as a bridging that can cause problems hemodynamically significant, and you cannot detect it in angiogram. Thank you.
So thank you very much. Thank you very much. With all these comments, now we'll see the our next presentation. Our next speaker is Dr. Zahid Chirag. He is a nuclear medicine specialist and he has diverse experience in nuclear medicine as well as in corporate sector. He has, after his medical degree, he has done masters in nuclear medicine, FEBNM certification, and also he has done MBA from Boston University. His experience is in nuclear medicine as a nuclear medicine specialist in Pakistan, in Saudi Arabia, and he has done his PET-CT fellowship at Singapore General Hospital and supervised teams and developed imaging protocols, gaining significant hands-on experience in PET-CT imaging. In addition to the clinical work, he has also worked that I have already told in the corporate sector. He served as regional product and clinical marketing specialist at Siemens Healthineers in Malaysia, and also presently he is also working as a freelance strategic molecular imaging consultant. He has multiple publications on his credit, especially during the COVID-19 pandemic. He has worked on the hematological disorders and all the things. He, in addition to these nuclear medicine qualifications, he has got 6 Sigma Black Belt course for the quality audits and assurance. So I invite Dr. Zahid Chirag, like his diverse career and expertise. He's talking something different, that is artificial intelligence in nuclear medicine, current status and future perspectives. Dr. Zahid.
Thank you so much, sir, for that wonderful production. And thank you, Dr. For this wonderful introduction. Before that, thank Dr. Mehdi. Thank you for doing that show of hand. It makes my life much easier because I believe my presentation has less of medical terminologies and more of things that could be, I hope, more interesting for the general audience also. So today we'll be just talking about the artificial intelligence in nuclear medicine, current status and future perspective, what it holds, what is the future like, and where do we stand in it and how do we go about it. Since everyone is putting up a lot of pictures, so I just had to go back to my Facebook account last night and dig up this image of Dr. Hussain is there, and Dr. Al-Ghazar is there virtually because he was the organizer of this event in 2011 in Kuwait. And Dr. Pati, most of you must have recognized this, was the India-Pakistan cricket semi-final 2011. We restricted India at 260, and then of course we started batting, and the rest is all history. Bhabiaz, I think he was brilliant, having 5 wickets in this match. So we are just following this with our tour. Everyone knows this image, Van Gogh's Starry Night, right? So we look at the grayscale of it. I mean, you can appreciate all the structures, all the forms, everything that this masterpiece has, all of you can see in this particular image. But there is something lacking. You cannot appreciate the complexity that the artist has put into to show you the different colors. There is a lack of depth in this image that you see in the original thing. This is something that, like Dr. Shazia mentioned yesterday, a comparison between Barbie and Oppenheimer. I think we are lacking the Barbie effect in this one, and the advanced technologies that we have in hand today, like artificial intelligence and other algorithms that are coming along, they are giving us this image that we want to see, that has all the details and that has all the perspective in it, all the in-depth and through the hard work. So this is something that advanced technologies are doing with the grayscale imaging. They are giving you the correct data, more in-depth knowledge of any analysis that you're doing or the image acquisition that you're performing. Just a short version of if you just search these two terms, and you can see that steadily starting from 1986 up till now, the terminology of artificial intelligence in nuclear medicine is on the rise, and there are a lot of papers that are coming around it, the publications, a lot of validations are coming around this topic. So in today's presentation, we'll just have an overview of it. Why nuclear medicine is employing artificial intelligence? Why do we need that? What are the state of the art technologies are coming? What are the roadblocks and what is the future like? Because you will agree with me that every nuclear medicine, I mean, as I say, a picture is worth 1,000 words, but in nuclear medicine, it's worth millions of data points that we have in there. There's a lot of information that we can get from combining all these points and to make a better use of that particular image and gather more information from that particular image. So this is what we'll be negotiating through with this presentation. It will not be a long presentation, so I hope no one is getting bored of it. So basically, with the advancement in technology of the industry revolution, because these are the four major revolutions, industry revolutions that we had, and medicine has been keeping pace with that, with the mechanization. Up till now, the big data and AI is basically big data. When you talk about it on the bigger forum, that is the new oil economy, I would say, of a lot of countries and a lot of organizations. It's not about the things that you see physically or tangible, but this big data and the employment that you do with it, it's basically shaping up the economies of the world economies also. And of course, healthcare sector is not an exception out of it. So we have been like keeping pace with it. From patient to image creation and back to the physician. This is the whole system that is working. There are opportunities of the AI systems to act at nearly all the steps in this medical imaging pipeline. And this improves our ability to care for the patient and give better results for the physician to make decisions accordingly. So it's not a simple process, and you can see that from injecting to the patient, imaging, and then coming up with the results, there are a lot of avenues, a lot of opportunities where we can have decision making, or we can have a lot of input from artificial intelligence in all these points. So it's basically an ecosystem of all the stakeholders. With nuclear medicine being in the middle of it, we have to look into all of these stakeholders. So just to go through these 2 points from patient to physician, you have to cater to the needs, and you have to look into the input of all the stakeholders accordingly. So basically, what is AI? AI is a simulation of human intelligence processes that is done by the computer systems. And these processes, of course, include problem solving, learning, and adaptation according to it. And AI is not just having driverless cars or the gadgets that we use. It has been showing a lot of promise in the healthcare also, that leads to opportunities for better diagnostics and treatment planning and treatment regimes that are being developed. Just to give you a market view of this particular technology, from for forecast that will go to 2028, it is said that from 14.6 billion, the market will go up till 102.7 billion. So that's almost, I mean, 5 or 6 fold increase. And North America to this date has been the largest share. The North American region they have come up with. So we can see that there's a lot of potential in AI. It's going to rule in the days to come. And there will be a lot of algorithms, a lot of development in this particular section. So the incorporation of AI in medical image, it roughly dates back to the early years of computer vision. So the moment we had computers coming into the imaging, it's the start of the AI that we had. There are a lot of algorithms. We'll not go into the technical details of like what is a convolutional neural network and what it's doing. But the purpose is that it leads to more accurate and quicker diagnostic. That is one of the most important things that we want to do with AI, is to increase the efficiency and the throughput of any department. That would lead to better and more early results. It is naturally extending into nuclear medicine. Like we are not exception, like with the rest of the healthcare facility as that phases. So nuclear medicine is into it, and why it's there? Because as I said, because of every image that we produce, it has a lot of data points. And nuclear medicine is one of the ideal field, I think, when it comes to imaging that can positively employ artificial intelligence in our work so that we can make these early detections and of course, help the clinicians devise individualized treatment planning. So as nuclear medicine offers rich data and unique diagnostic capabilities, I mentioned that it comes with challenges. We have high volume data, sensitivity to patient movement and noise interference. So these are all the issues that we need to address in our daily routine job. So AI has the potential to address all these challenges, making it easier to detect abnormalities and go on with the patient treatment. So the AI technologies currently used in nuclear medicine, they primarily focus on image analysis and disease classification and treatment prediction. These are the three most important areas where AI has been working at the moment. Adoption rate is very steady by the physicians and the clinicians world over. There are a lot of factors behind it, but it is regularly it's going on. Regulatory bodies, they are the most important stakeholders because they are the ones who will be testing these AI algorithms and considering them being safe for the human, for the healthcare users also. Just giving you an example of a recent medical technology giant, they had their new PET-CT camera rolled out. It came up with an efficient artificial intelligence program also. FDA did not give that approval right away with the machine. So the machine, the PET-CT camera was launched a year before, and the FDA approval for that particular AI that came along after about 1 year, almost 1 year. So they are one of the most important stakeholders in this. So in the clinical sphere, AI algorithms are the programs that are being used to execute that particular task that we want to do. So they are enhancing diagnostic imaging and enabling more accurate classification, of course, and they aid in patient-specific therapy. Since we are moving to an era of theranostics very fast, so in the times to come, every patient is a different patient, and everyone will be needing a different kind of personalized treatment. So this will be something I think we should be looking on to as nuclear medicine physicians, and that is surely to come in the days. So there, as I said, there are multiple algorithms that is beyond the scope of our talk, but they have been there, and they work in different manners. Like if we are talking about classification, or we are talking about taking a disease, or we are talking about to improve the signal to noise ratio. So all of these algorithms, they work differently, and they have their different outcomes. Hardware important, the most of important, like you cannot just have it in a USB or something that you just install some program into a system and it becomes AI enabled. So the hardware, of course, there's hardware, and then there are cloud-based interventions also. So the cloud-based intervention is also reason that it's making a lot of progress in these days. And of course, technologies will keep on emerging, new algorithms will keep on developing, and they will be coming out developed by the medical technology companies. Just to look at the patient flow, if you like, if the patient, what is the kind of the workflow, or I would say the pattern that you see normally in a patient, that you have, first of all, cancer prevention, most importantly, if you can then, secondly, screening, followed by diagnosis and treatment and response and follow-up. The boxes and the pinks are the one where AI can help in decision-making, or not, I would not say decision-making, but give you additional information to the physician to make a better plan, to make a better outcome for this patient. So there are a lot of opportunities, as I earlier told you, for AI to be working in all these areas. If you want to look into the neural network of this particular, the patient pathway that we just spoke about. So these are the kind of the background, I would say, things going on that lead to development of these AI models. And these are, of course, a lot of heavy terminologies there, and we don't need to go, but this is the flow. This is how AI algorithms are being developed and the areas that they focus on. So it's basically the gap from the model development. Model development is for the patient that we want to work on, and what is the clinical impact that technology is going to have. So to bridge this gap, the technology that is developed, it has to be valid, It has to be valid for the things that we are doing. It should be usable for everyone. Like it doesn't need special expertise to be handled, and it should give you the outcome that we are looking for. It should address the specific questions that we have in this regard. Just to give you a list of a few of the already introduced AI algorithm and technology that are being used by multiple vendors, and you can clearly see that 2015 onwards is the time that they have taken off, and there are a lot of work that has been done, and they are still doing a lot of things. Nuclear medicine is not the primary field where you will start off with the AI. It's mostly, it's coming down, trickling down from CT and MRI and all these morphological imaging. So we are picking up. The progress in nuclear medicine is not at the same rate that we had in CT and MRI, but it is at a continuous rate trickling down to nuclear medicine also. I would just like to present one paper on cardiology in which the AI model was compared with a couple of nuclear medicine physicians, and their results were looked upon to. It was a single center study, prospective study, and it was they were comparing the automatic virtual, the mitral valve plane, the detection of it to those that was done manually. So the results were quite good. For attenuation correction images, model actually aligned more closely with the expert consensus than the experts did with themselves, each of themselves. For the non-attenuation corrected images, model performed about as well as the human did. However, there were, of course, there are a high number of cases and errors in both of them. But in short, they concluded that for this particular parameter, the machine learning model is proving to be a very useful tool, with, of course, a few limitations. When they looked into the TID, the transient ischemic dilatation of the ratios, the model that they used, it shows commendable agreement with the expert opinions in evaluating this particular parameter. And similarly, for the another parameter, total perfusion defects, the AI model demonstrated high level of agreement with human expertise in evaluating the global TPD, with biases similar to those observed between the two human experts. So they concluded that the study concluded that there is significant advancement of this application. It can help in the ventricle position localization and eliminates the need for more expert human intervention for these contour detection. And of course, it improves the efficiency, overall efficiency of the department, and reducing the time and potential for any human error that can be introduced. So in the summary, they said that it was this machine learning approach was more objective and reliable method if employed with quantifying MPI. Another study from neurology, it's just one study, there are 3 or 4 studies in which they used AI algorithms, the machine learning processes in multiple neurological diseases, and they come up with very promising results with Parkinson's, Alzheimer's, and other progressive neurological diseases. So artificial intelligence tools can be conceptualized that they are doing three broad categories of image clinical tasks in oncology. They are detecting the abnormalities, they help, I would say, they aid in detecting the abnormalities, characterizing the suspected lesions, mostly for the lung nodules. There's a lot of work being done with lung nodules also. And then try to determine the progress of these particular pathologies that they come across. So this is the mainstay that AI could be looking at, and they will be working on this in future. So if you look at a normal clinical workflow and the AI points that we have. So in traditional paradigm, what is done with the patient? You have this radiological diagnosis, then there's a treatment decision by the patient, the preferences, how to go along with, and what are the clinical factors that you need to see, and the diagnosis, of course, the final diagnosis always after histopathological diagnosis. So again, if you look at the pink boxes, these are the interventions that can offer to augment this clinical workflow in the patient and decision-making at various points in the continuum care of any particular patient. Radiomics, one of the most important fields that we are working upon. We have a lot of studies coming on. The results are promising with AI, of course, but still it's a preliminary stage. The clinical implementation is not there at the moment, and it still requires further validation and evidence validation to be more generalized for everyone. Everyone knows this image, right? What are we looking at? It's a Mona Lisa, of course, thank you.
what is this? Is this Mona Lisa? Okay, and of course, it's Mona Lisa with, of course, with a lot of background, with a lot of detail that we have. So this brings us to a couple of points. AI is a tool of clarity. So AI does have this capability of sharpening the images, enhance the contrast, and even help in identifying multiple pathologies that could not be in that focus. So it aims to offer you a clearer picture. What is the risk? Risk is overinterpretation of that particular disease. Like we have been like looking at the Mona Lisa portrait for a long time, but this risk we are not looking at. So do we need that? Is it there? That's a very important question. Is AI cooking up some data, or is it showing us the clearer, sharper image of what already exists? So this is one risk that is with AI, and that is one of the a lot of studies have been done that, and to validation that this is the one of the issues that regulatory bodies also look into very deeply. Is it relevant to the clinical practice? The clinical setting, such is this imagination, this kind of imagination, could it be dangerous for the patient, for the work that we are doing? Could this lead to false positive or negative results? So this needs to be validated. The oversight should be there, and all these systems, they need a complex validation process they have to go through before getting the implementation. Ethical and clinical consideration before you rely on any kind of AI-made critical decision. Is the decision ethical? Is the physician weighing it according to the clinical scenario that we have? Is it in line with any kind of Hippocratic oath of AI that we might have, the AI systems might have? Don't just push since AI is pushing the frontiers, but don't just jump onto the computational clarity, I would say, towards the clinical truth. There's a computational clarity, there's a clinical truth, because after all, everything that is clear is not true, and everything that is true cannot be clear. So these are the challenges that we definitely look into. So we just spoke about these ethical considerations. Very important. Who has the data ownership with the data generated by AI? Is it the machine? Is it the cloud? Is it the company? Is it the physician? Who is owning this data? Do we have every kind of patient consent that we will be putting their images to this particular process? That is a very important question. And of course, algorithm, because physicians don't understand these algorithms. It's a kind of what is termed that it's a black box that has a lot of input and there's an output. What's happening in that black box, that's very important. No one really understands product. So there's a new phenomena that is coming on, that is understandable explainable AI, XAI, that everything that AI is doing, it should have some logic behind those decisions, and it should be explainable to the physician and to the patient equally. So one of the papers that looked into these kind of trustworthiness issues with artificial intelligence. So they came up with 5 basic points that how do we develop this trust between that AI and the physicians and the patient. The quality of the data has to be validated. The bias, the algorithm bias that they have to address that. It should be very much opaque. You should know what's happening in that and how did a particular decision was made, the computer decision was made with that patient. It should be safe and security. And finally, most importantly, responsibility. Who is responsible in this scenario if there is a mishap with the data privacy, the patient's, let's say a decision was given and it was executed. If it's wrong, the strategy is wrong, who will be held responsible? So this was a wonderful paper that looked into multiple issues regarding legal and regulatory aspects also. So any AI development, or for that matter, any technology that is developed, it has to be human-centric. It has to be taking care of because in the end, it's the humans who will be getting treated, not the machines themselves. Another paper that also looked into the similar kind of thing and it was termed that AI is, of course, a game changer. It's improving the workflow, it's improving and enhancing the research capabilities, but of course, it's not a free pass. You have to look into ethical, social, and all the bigger issues that we had. So it's a kind of double-edged sword. It's an incredible tool, but you have to be very much careful while using it. So multiple challenges and limitations. If we talk about that, the data that is being put into the data that is being curated, the interpretability of all those lesions, the ethical concern, the regularities, of course, like FDA has just spoke out and said we very keenly, religiously follow FDA clearances and the European clearances. So that is very important. Data privacy and security, it's, I think, more a bigger issue that comes from Europe than from our side. So these are the all kind of things that has to be the integration with your existing hardware, existing system. Is it compatible? What do you need to do that? And of course, how will it address any incidental findings that may have? Future direction, it's good. We can be very much hopeful that there are a lot of good things that we can have while going down the way. The transparency tools will improve, they are improving. Data sharing would be a very much, I think, the game changer when it comes to AI with the machines learning there from all the data and that data being shared globally. And of course, the cost efficiency would be a very important point in this because countries like Pakistan and other developing countries, the implementing could only be possible when it's cost effective and that caters to all. But the work is being done in this aspect also, and hopefully it will be very nice. So just wrapping up, these are the few qualities that any AI algorithm or system that should be having. It should be looking at all holistic approach towards all the stakeholders, the patients, the institute that are running it. It should be transparent, should be explainable, it should be fair, and most importantly, privacy. And someone should be controlling all of this process. Coming back to our picture of again, Starry Night will only be Starry Night that if it has the original color, the originality, and the original complexity. If you just stay in the splashes of yellow and blue and whites, it will give you something similar to the original masterpiece, but it will not be the original representation of that particular piece of art that we have. You have to strike the right balance. Just consider it as an overeager intern or resident. They are full of potential, prone to make mistakes, but you need to have checks and balances in past so that it's a system that is robotic enough that can make you a very good cup of coffee, cappuccino, latte, whatever you want. So you have to embrace that, but you have to keep remembering, keep an eye on the view that it stays in what it's supposed to do and it does what we want it to do. Thank you so much, and I hope it was not medically loaded presentation, and I hope everyone was awake during this presentation. Thanks a lot.
Thank you very much, Dr. Zaid. You can make the questions. What I understand with your presentation is that considering all the factors and tools, the basic thing is the development of a model that considers all the
That
things.
is very important. Just let me give you an example. I think 2015 or 16, Mercedes-Benz came up with this idea of driverless cars or something, and they had to develop a model. They gave, I think, 10 to 15 models were inserted into the program of that machine. Like if you're going at a highway at 100 miles or something, and you have suddenly there's someone on the road in front of you. So what is that algorithm going to do? Is it going to save the passengers of the car, or is it going to save the pedestrian on the road? So these are the kind of balances. So these are what we are talking about, that these algorithms have to address these challenges so that machine gives you a kind of input that is very much important and that is very reliable and authentic and logical enough to
Yeah.
Considering the time constraint, we have only 2 comments.
Oh, okay. I'll
If there
keep
are
mine,
many, we can
I'll
discuss.
keep mine short. I think it was a very interesting talk and need of the day. And like the last slide mentioned, that artificial intelligence can never replace the role of a physician, right? And your topic was primarily artificial intelligence, AI in nuclear medicine. But we did not see a lot many examples how, it can be incorporated practically in nuclear medicine, other than one slide showing lung nodule segmentation maybe and prognostication. So I believe you could have added more of that. And then you touched upon radiomics, which is very, very important part of AI. And for those of us who do not know or are not familiar, I think if you can elaborate a bit about that as well.
Thank you very much for this comment about I was waiting for someone to bring this up. Would it be replaced or something? You have to look for the AI system. You have to look into as I mentioned, look into the clinical efficiencies and workflow that our department is doing. You don't have to see it as a competitor. See it as an assistant that is, any nuclear medicine scan that you, there are three important parts: patient preparation, imaging, and then followed by reporting. These are the three important venues where AI can help you with the patient selection, the protocol selection, and all these are ultimately what it leads to, the prime, what we should use it as, becoming more efficient, taking out all the redundant work from our workflows and become more leaner towards the work that we are doing. As I mentioned again, nuclear medicine is newer when it comes to, relatively newer with the artificial intelligence. Most of things that we are doing, even when you are the lung nodules that we are talking about, it's the CT thing that we are doing. It's not a nuclear medicine focused algorithms that we have. Let's say 5 years from now, if we have the similar conference, maybe we'll have a lot more papers, lot more images, specifically from nuclear medicine that might have less of an electrical imaging and more of, so it's the artificial intelligence is rather newer to this scenario. The medical technology giants are trying to sell these this proprietary to everyone. So that is one main reason that you don't have more images. It's mostly with the old breast imaging and the lung nodules and neurology. But thank you for the comment of this. Of course, that's a very fair comment.
Thank you very much, Dr. Zahir. The rest of the questions which you want to ask from Dr. Zahir, I think he'll be available during the tea session as well. We'll move to the last part of this session, and that is the diagnosis of the infection, role of PET-CT. This is the second part. The first part was delivered by Professor Al-Ghazari yesterday, and of course, we have given his introduction yesterday, a brief outline, just a few things, because currently he's working as a professor and chairman of nuclear medicine department at Kuwait University and has received 14 awards from several international professional organizations and a member of editorial boards of several medical journals. He has authored and co-authored over 150 peer-reviewed scientific articles and has authored and edited 10 textbooks and 6 book chapters. He has served as a reviewer of the Journal of Nuclear Medicine, JNM, and several other medical journals. Professor Al-Ghazari, please. The second part of diagnosis of infection, role of PET-CT.
Good morning. And after all of this sophisticated stuff, we're going to go back to some basic clinical. And this second part is concerned with the skeletal infection. Doesn't wanna. Okay. Fine. That's okay. Yeah. Yeah. Okay, so when I say skeletal infection, I'm reminding you that skeletal infection is not synonymous with osteomyelitis, because skeletal infections include less aggressive or less extensive kinds of infections, including periostitis and osteitis. And why I am reminding you is this, because these conditions can cause some trivial findings or abnormalities on scintigraphy. And we should be aware of this, and we don't ignore it, particularly in pediatric age groups. Now, for skeletal infections, as with soft tissue infections, we have morphologic modalities and functional modalities. And the strategy and the recommendation in the last few years have changed, and I'm going to update you about the new changes and recommendations. And without going into much detail, MRI, as I mentioned last time, is now from the outset the modality or the first modality for the diagnosis of skeletal infection. It was not like that before, but it was used in certain indication. And typically, we are not going to just go into any details, but typically it shows low signal in T1 and high signal on T2. CT is less useful with some exceptions, including in the detection of certain findings in chronic osteomyelitis, particularly such as the Brody's abscess and cloacae and all of this stuff. But importantly, also, it is known to detect the intraosseous gas. And why I'm saying that, because there is one condition that we may miss commonly. It's a subtype of osteomyelitis called emphysematous osteomyelitis, which happens most commonly in the spine, and it has a high mortality, not only morbidity. So CT scan and consequently also SPECT CT with the CT component could be instrumental in detecting the emphysematous osteomyelitis. Now, here are some examples. The radiograph is showing here a some osteolysis, but why I am putting this? Although, as I mentioned, MRI is the most important now, and the other modalities, but X-ray has to be the first modality, imaging modality, when imaging is needed. X-ray must be the first modality, although it is not, or it doesn't have enough accuracy, particularly if there is a previous history of bone pathology. But still, it has to be the first modality to be performed in any suspected bone conditions, including infection. Ultrasound sometimes is useful in pediatric age group. CT, as I mentioned, this is a Brody's abscess in a child, clearly identified by CT. And here is a gas within the body of one vertebra as an example of emphysematous osteomyelitis. MRI, and here is an example with increased signal on T2 as an example of osteomyelitis in the right proximal femur. And here is one of the current recommendations. We used to put here, if the X-ray is not conclusive, which is common, we used to go right away to the functional changes with the MRI as complementary in depending on the location and the availability and so forth. Particularly, for example, in the spine infection. But now, the MRI is done first, and this is particularly recommended in pediatric age group because the objective is not to expose also the child to any radiation exposure, despite the fact that the routine bone scan doesn't expose the child to a high radiation dose, but it's a principle. And actually, in many studies from the outset, the currently available MRI provide accuracy close to bone scan. Now, if the MRI is not available or it contraindicated or cannot be tolerated, functional images then is the way to go. And the bone scan, of course, is the first among the functional imaging, and classically you see focally increased the flow, blood pool, and delayed uptake. But there is one variant of osteomyelitis that causes increased perfusion, here is on blood pool, but cold defect on delayed imaging. And this is called cold osteomyelitis. It is more aggressive. It causes more significant signs and symptoms. It may require hospitalization. And we have to be aware of this in the interpretation because we may just miss it as we always look for the increased tracer uptake in osteomyelitis. SPECT-CT, again, the nice presentation in the morning showed the added value of this hybrid imaging. It can clarify, here is a whole body and planar imaging, and you can see a little bit of asymmetry, but you may not be sure whether this is a real abnormality or not. With the better contrast of the SPECT and the correlation with CT also, you have more certainty that this is abnormal, and you can compare both sides here versus both sides on the planar. You will see clearly the abnormality, and you are more certain of your diagnosis. Now, we shouldn't, sorry. We shouldn't be confused if we deal with infectious arthritis, which is common, particularly in pediatric age group. And here, there will be increased flow, increased blood pool activity, as well as certain changes on delayed image. But the difference is, one, the increased perfusion, as well as any changes, if any, on delayed images, has to be periarticular and confined to the boundaries of the joint capsule. So if we see on one side, or we see it outside the joint capsule, it can be osteomyelitis, and both conditions can coexist. On delayed, characteristically, either you see almost normal findings or little bit of residual hyperemic changes, as you see in this case, within the capsule or a little periarticular, but no focal abnormality as the characteristic finding on osteomyelitis. Cellulitis also is similar. You see the flow and the blood pool, and it doesn't have exact distribution in the joint or around the joint. And typically on delayed imaging, it's normal. Now, certain types of skeletal infection need some attention. Spondylodiscitis, or what we call it vertebral osteomyelitis. Spondylodiscitis is a better term because the disc is almost invariably involved with the end plates or vertebral body sometimes, and that's why spondylodiscitis is a better pathologic term. And the MRI is the way to go for vertebral conditions, including actually any vertebral injury or pathology. MRI is the way to go, including even sometimes malignancy. MRI can detect some metastasis that otherwise cannot be detected by other modalities, excluding the PET, of course. Now, yesterday, I touched to the chronic active infection. And regarding osteomyelitis, it is the same and even very serious to differentiate. Here is a case of tuberculous osteomyelitis. And in this case, this is a chronic osteomyelitis from the outset. And when you do labeled white blood cells, expectedly, as we mentioned, it's going to be either negative or trivial findings that may not be enough to confidently diagnose skeletal infection. So here is an example. So what to do? Here is another case. This is one of the cases that I saw a few years ago. And you can see here, the flow should increase the flow in the distal end of the right tibia. Blood pool, same thing. And here is a delay. And this indicates osteomyelitis. However, because this patient has a history of acute osteomyelitis several years before, so we need to evaluate whether it's active or not. So one of the junior physicians requested labeled white blood cell, and as you can see, it's negative. And then I asked right away for gallium 67. And here is the gallium uptake in the same area. And it's not seen in white blood cells. This indicates active infection rather than chronic quiescent osteomyelitis. Because osteomyelitis particularly can stay with no problems at all, even for 20 years or more. And then after that, it can be reactivated because the microorganism can be dormant and reactivated for whatever reason, whether related to immune system, whether related to minor trauma. I can't put my hand exactly on the reason. SPECT-CT again is important, and here is one of the cases of chronic osteomyelitis, and this is a PET-CT case actually. Here is the planar imaging, and you can see a little bit of asymmetry here, but with FDG PET, you can see it very clearly, and it corresponds to the CT findings here, and this is a case of proven chronic osteomyelitis in a child, and this is the same case that showed the Brody's abscess that I showed you before. So Brody's abscess with FDG uptake means it's a chronic active infection. If the FDG is not positive, then this is just necrotic tissue surrounding a granulation tissue from previous infection. And accordingly, for chronic active osteomyelitis, FDG PET-CT is the most accurate modality to determine whether this is chronic active osteomyelitis. If it is not, or it cannot be performed or not available, then you do combine the bone and the gallium 67, as I showed you the couple of examples, or the example that was clearly positive by gallium, which can determine or provide similar information to FDG PET. Now, the FDG, continuing with the FDG, is becoming more important in diagnosis of skeletal infections, and it is actually the modality, the functional modality of the choice for the diagnosis of vertebral osteomyelitis. So we do first MRI. If there is any reason that we could not do it or not conclusive, then the FDG PET-CT is the way to go. And here are a couple of examples. This is showing in the plates changes and the FDG uptake in the same area. And here is another case with uptake also extending beyond the bone. Now, and actually, believe me, when I was discussing with some of the good scientists here about this, PET-CT may not be available in certain areas. And we have to consider the culture diversity. We are not going to let the patient die because we don't have a PET CT. So if we don't have PET CT, again, go for gallium-67. And you do bone and the gallium and compare if it is congruent or not congruent, and if compare the intensity and the extent. So if the bone is more than gallium on planar images, this is not osteomyelitis, but if the opposite, it indicates vertebral osteomyelitis. And Palestro and Love from New York, they believe that gallium SPECT-CT is as good as MRI and as good as combined bone and the gallium SPECT-CT. So they achieved an accuracy of about mid-90s. I personally believe that when we deal with gallium, we have to have a bone scan as well. So we have alternative to the FDG for the spinal infection if it is not available. Now, let us switch to other categories of skeletal osteomyelitis, and we can group those diabetic foot as well as periprosthetic infection and the post-traumatic infections to simplify the issue. For the diabetic foot, we as nuclear medicine specialists must have enough information about the patient and check if the patient has an ulcer, and even if it is wrapped, we have to unwrap it and see it, and also may mark it on imaging. This is very important because depending on the ulcer and the duration of the disease, you will determine certain things. And as I mentioned always, it was proven that if you have a deep ulcer exposing bone and the patient clinically has symptoms and or signs indicating infection or suggesting infection, there is no need for imaging whatsoever. It should be treated as skeletal infection or diabetic foot infection. But if the ulcer is not exposing, then we need imaging. Although I mentioned about MRI, in general, MRI is not accurate for diabetic foot osteomyelitis, as well as FDG PET-CT, because the data are conflicting. So what is the most accurate for the diagnosis of diabetic foot infection is the labeled white blood cells. And I can, just 1 second. I don't know why my hand goes to the, I can, if you have a SPECT-CT of the bone and white blood cell, and if it is positive, we have to add sulfur colloid bone marrow scan. Why? Because indium or technetium labeled white blood cells can accumulate in the bone marrow. And someone will tell me, why bone marrow in the foot? because there is a reconversion theory for the bone marrow, because when the bone marrow evolves to the adult pattern about the age of 25, there is an evidence that few cells will remain in the almost entire skeleton. With injury, including infection, it may regenerate and form a focus of bone marrow, which will take up the labeled white blood cells. So we need to differentiate between infection and the physiologic uptake in any of these locations, including the foot. So if the bone marrow is congruent with the focus of uptake of the labeled white blood cells, it's not infection. If it is not congruent, different, it is infection. And here are a couple of findings here. Here is a focus of uptake on bone, and here is the white blood cell with no corresponding uptake. So this is infection. And here is another one which indicate that this is a physiological. So when we have suspected diabetic foot, post-traumatic osteomyelitis or periprosthetic osteomyelitis, although generally the current recommendation is to start with MRI, but the accuracy is not enough. And then the most accurate is the bone scan labeled white blood cell. And only when the labeled white blood cell study is positive, you add the sulfur chloride. Here is a periprosthetic, and actually there are too many reports that came about maybe 10 years ago, praising the FDG pit in periprosthetic infection, but the data are not consistent, and actually it didn't stand in this area. Accordingly, again, we'll use the same thing. Here is a bone scan, and here is a white blood cell study. You can see uptake here, and here is the again the bone scan along with the white blood cell, and if positive, as I mentioned, you go for the sulfur colloid. Here is the uptake in the white blood cell, two spots here. One has the sulfur colloid corresponding and the other is not. So this is infection and this is not infection. Now, let us summate this, and the next slide is the conclusion. We should start with the plain film or X-ray. If it is diagnostic, which happens in about 40 to 50% of the time, if the bone is non-violated. But if the bone is violated, it can be as low as 3 to 4%. But still, it's important to do it first. If it is not diagnostic, overall, we go for MRI. If it is not conclusive, we ask ourselves, are we dealing with a non-vertebral location or a vertebral location? If it is non-vertebral, we go for the bone scan. And if it is negative, we stop. If it is positive, we determine whether the bone has been violated by another pathology before or not. If it is non-violated and the bone scan is typically positive in the proper clinical setup, this is enough for the diagnosis of osteomyelitis. If it is violated, such as in diabetic foot or post-traumatic or periprosthetic, we have to do the white blood cell with or without a sulfur colloid or FDG. If it is vertebral location, the way to go is FDG or gallium if not available, as I mentioned. And in conclusion, for the entire two parts, we have to understand the pathophysiology of different forms of infection and choose the most cost-effective and time-effective modality depending on understanding of the strengths and the weaknesses of each modality. There is expanded role of MRI, as I mentioned, particularly in pediatric age group in skeletal infection and in many conditions in soft tissue infection. PET-CT again is very accurate in many conditions of the soft tissue and bone infections, including fever of unknown origin, infective endocarditis, chest infections, chronic active osteomyelitis, and spondylodiscitis. Gallium is still useful when the FDG is not available, and the hybrid imaging, again, as mentioned this morning, whether you are dealing with SPECT-CT or PET-CT, is very useful in imaging infections in general. Here are two books. The right side one, the synopsis, I send it as an ebook, and it has the most recent recommendations in one of the chapters, because it was published just 2 months ago. The other one, I give a copy to Dr. Shazia, and thank you very much for your listening.
Thank you very much, and for a very nice presentation. I think it covers the topic of infections, imaging, especially PET-CT and the role of the gallium. As we have short of time, the questions can be discussed or asked during the tea sessions, or Dr. Professor Al-Guzar has another talk in the last session. You may refer the questions to that session. So with that, we are here ending this session, and there will be a short tea break. As we have running short of time, I request all the participants to be present over here within maximum 15 minutes. So at 11:40, as per this clock, all the participants are requested to be there. Thank you very much.
So welcome back after tea, and we are ready to start the second session of today and the fourth session of this workshop. This is going to be chaired by our Dr. Mohammad Tahir Khaliq, the President of Pakistan Nuclear Society. I request him to come to the rostrum and conduct the session.
Assalamu alaikum. Now we start the second session of today. And there are three speakers. First speaker is Dr. Ahmed Hassan Nawaz, PhD. Dr. Ahmed Nawaz held the position of faculty head of the Max Planck Institute for the Science of Light in Edinburgh, Germany. Prior to coming to Pakistan in 2015, he received Marie Curie Fellow at TU Dresden, Germany, where he completed his doctoral research in 2009. He was granted a Fulbright scholarship into pursuing his PhD at Pennsylvania State University in the United States. He received Best Research Dissertation Award for PhD research. To date, Dr. Nawaz has a publication record with over 32 research papers, research articles published in international journals. Along with 9 conferences proceedings and 3 US patents, his research has generated attention from US local US newspapers and Penn State of News. And his article have been cited over 2,000 times in esteemed international research publication. Earlier, he was awarded the European Union Erasmus Mundus scholarship to pursue a double degree master's program from 2007 to 2009 with the first year at the Institute National Polytechnic, the Grenoble, France, and the second year at Eisenberg University, Germany. Dr. Nawaz obtained his bachelor's degree in metallurgy and material engineering from Ghulam Isa Khan Institute of Engineering, Science and Technology, where he was awarded the gold medal by the President of Pakistan in recognition of his exceptional academic performance in 2006. Now I invite Dr. Saab to start your presentation.
Just a bit more comfortable walking around, so I hope you guys don't mind. Okay, thank you very much, Dr. Saab, for a very elaborate introduction that just humbles me more. So today I'm going to talk about, basically I'm going to start a bit more unconventionally, and you can, let me start with a nice animated Maya video that I developed during my last 7 years of research. And this is basically going to summarize what you're going to see in the next 30 minutes or so. So consider these as cells, blood cells, let's say, or tissue cells that have been disintegrated. They are allowed to pass through microfluidic channels, and as they pass through a channel region which has laser light focusing on the cells, basically what's happening is scattering of light, and that is what brings about information about the cell. And if, because you are all medical doctors and you might have heard about flow cytometry, that's the gold standard for diagnostics of different diseases. So this is basically a miniature replica of flow cytometry. Okay, so again, some fun videos, because as you know that my talk is about use of artificial intelligence, right? So this is a video that I just took from YouTube, right? Just try to see how this robot from Boston Dynamics is going to learn how it makes mistakes and then starts to learn that this mistake I should not make again, and then balance myself out. So you saw how initially it fell down, but look at it, it just got up. And these are real robots, right? So things are happening. It feels victorious. Okay, so just very quickly, the self-driving cars are the talk of the day today. So, these Tesla cars, they drive by themselves. They just detect where the road signs are, and then they can go along the road and hopefully not hitting into things. Okay, I'm not going to stay too much on this slide. So this is what you will see in the next, but in a more elaborate, in a more research manner. So I'm going to talk about the work that I did as the head of Max Planck, facility head at Max Planck Institute. And it was published in Nature Methods very recently. And basically, Dr. Saab has already introduced me. Let me try to skip this slide. Let me give you a brief notion of what microfluidics is. Microfluidics is when you allow fluid to flow through a very tiny channel, say the size of your human hair, right? Like tens of microns, 20 or 30, whatever. And then, long story short, in layman terms, when you turn on the water from a tap, you see that it has turbulence in it. But the same water, when it flows through a microfluidic channel, it just behaves as if it was honey, right? That's just layman explanation of what microfluidic is, right? So let me start by a fun example of microfluidic. You remember this very famous Roberto Carlos cake that is hopefully going to play. Let's see. So everybody thought that this goal or this football was going to go outside the post, but it went inside. What we did at Augsburg during my master's, we were able to replicate just for fun. These are just look at the scale. It is 600 micrometer, and you can manipulate using sound waves. You can manipulate very small particles and then lead them to direction where you want. But today we are going to talk about more complicated examples of microfluidics. You all have cell phones, I believe, in your hands, right? So these cell phones have very complicated SMD components of electronics. That means that these are components sometimes so small and they are produced in clean room. And this is a representation of a very complicated multi-layer electronic circuit. But in microfluidics as well, you have something very similar. And that's, for example, here you are represented with a PCR microfluidic device, polymerase chain reaction device. And look at the size, you can see it next to the dime. And it's a multi-layer channel device, not the topic of today, so I'm not going to go into the details. A quick question, what do you see here? Twins? You all are doctors, you know already. I don't want to ask you some more rhetoric questions that are coming back at me. But basically, you know that there are differences in twins as well. Like, for example, the retina of the eyes or fingerprints, for example. Everybody has different fingerprints, even though the शक्लें एक जैसी भी लगे फिर भी fingerprints different. So you know that each and every cell has a transcriptomics or genomic background, that it is different from different cells. And that's where the science or the biology really starts. For example, in transplantation or regenerative medicine application, you need to have, or you need to study cells, each cell differently, right? And the first step in studying those cells is that you need to separate the cells out. You need to isolate the cells from the rest of the cells. For example, if you want to study the red blood cells or a certain type of red blood cells, let's say, if somebody has some problem with the red blood cells, like broken cells, I don't know what the medical term for that is, but let's say you have to separate those cells out and then you can only study them. And that's the reason why there is a lot of delay in, for example, when the coronavirus came out, everybody was thinking that इसकी दवाई क्यों नहीं आ रही बाहर और क्यों इतना टाइम लगा. Basically, the reason is that you need to first separate those cells out. Step number one, remember, you need to separate those cells out. And once they are separate, you can apply tons and different thousands of different drugs and then study the efficacy of those drugs, whether those drugs are going to work on those cells or not. So step number one, remember, isolating the cells. There are tons of different techniques for doing those. For example, the bulk separation technique like filtration, magnetic or MAC, magnetic activated cell sorting. I won't go into the details. I think you guys already know more than me about this. And again, I would put a little bit emphasis on microfluidic techniques. For example, in microfluidics, people are using microfluidic channels to run cells through them. And then there is an array of pillars uh, produced at certain angles. And as the cells pass through those pillars, the smaller cells are going to pass straight. And because they are designed in a certain way, the bigger ones are going to travel to the right. Just a very simple thing. But the state of the art, starting from 1950s, the gold standard for analysis of blood or any kind of disease is flow cytometer. Flow cytometer, as the word says, it's study of cells while they're flowing. And the basic phenomenon of flow cytometer allowing them to pass one by one through a laser light. And that's where the magic begins. The laser light is going to shine on the cells, and as the light scatters, it's going to transmit information, and that information is something that we are looking after. And sorry, long story short, you are conjugating the cells with antibodies. The antibodies in turn have fluorophores on them, and as the cells conjugated with the fluorophores and the antibodies, they pass through the laser light of certain wavelength. It emits, it absorbs the light, and then emission happens. And that emission is something that you are interested in as, you want to diagnose the disease. For example, if somebody has malaria, which is of a certain level, let's say less or higher level, then the amount of conjugated antibodies that go and attach to the cells and get detected, and they occur in different quadrants. That is what is going to detect the disease. Let's move forward. Okay, so one just thing that I would like to mention, since I mentioned and stressed a lot that you have to separate the cells out in order to study them, and that's the basis of the flow cytometer plus the cell sorting part that makes the commercial stack fluorescence activated cell sorter. So, but do you realize that this machine that you have, all of you have in your hospitals, this machine can sort cells, but you have to add antibodies to them. And if I'm not wrong, these antibodies cost quite a lot. I think I've been told that a very small bottle costs like $300 or so, depending upon what kind of antibodies they are. But they require labeling, and Allah subhanahu wa ta'ala has not attached those labels on the cells. Let's say if you want to use the cells again after they are being analyzed, for example, in transplantation of cells, stem cells, say, or you want to treat the cancer or personalized medication in that sense. So could we figure out a way that you don't have to label the cells, but still do the 7-part differential without attaching any kind of labels to the cells? And that's what I'm going to move towards. But before that, let me change gears a bit, make you a bit more comfortable. How would you buy tomatoes in a supermarket? Answer is quick. I have less time. What's that? Now, how would you make a decision to buy those tomatoes? Yeah. Very right, right. So you have to see physically, your eyes are looking at the tomatoes, and apparently jo aapko acha sa lagega, you'll pick those up. And the second, that's one thing. And then the second thing is subconsciously, when you hold the tomato in your hand is checking something, how hard or soft the tomato is. Probably you want to pick up the one which is extremely hard, paka hua nahi hai, whatever, right? But those are the notions that we had, or the simple notions that I would like to ask you to keep in mind, so that for the next coming slides you can realize where we are going. So basically, these are mechanical features of the cell. And can we use these mechanical features or mechanical phenotyping of the cells for taking those properties as inherent properties, right? And the gold standard that have been there for, I think, at least 3 decades, I know, is the atomic force microscopy. What you do is that you have a cell lying on a surface, and you probe atomic, probe, and you push the cell in. How hard or how less, the same concept that was happening in selecting tomatoes. The same concept is happening here. And as you push the cell down, you would get information about the mechanical properties of the cell. But you can well imagine that this is a very slow technique. In 1 hour, maybe if you're really good at it, maybe 10 cells, that's it. And then my ex-boss in Germany, he developed this technique of 2 lasers shining on a flowing stream of cells. And as the cell passes through the 2 streams, sorry, 2 opposite side lasers, he changes the beam quality, or you can say the Gaussian distribution of the laser, and it pushes the cell apart without physically touching the cell. This is called optical tweezer. But this is like 10 cells per minute. This was 10 cells per hour. This was 10 cells per minute. This is really slow. It's going to take you probably, I don't know, hundreds of years to analyze cells which you really want to, or which you do analyze in commercial flow cytometer. By the way, commercial flow cytometers have speed up to 50,000 cells per second. I think you guys know that. So what we came up with is this microfluidic device. And this microfluidic device, I have some of them with me as well right here, so that you can get an idea of how small the footprint of the device is. Let me pass those on to some of you, and you can feel which of the pass guys, please. That's about healthcare research. Kindly wait here. Okay, so this is the device that you see in your hands, or you are going to see in a couple of minutes. And even though there's this euro next to it, but you can feel in your hand what the footprint of the device is. But that's not the point. The point is that I hope you remember the number of cells you were analyzing at atomic force microscopy, or in that optical tweezer, 10 cells per hour or 10 cells per minute. But I hope you can appreciate the speed with which the cells can be analyzed, because this is a real-time video taken from one of those devices that you have in your hand. So these are red blood cells, white blood cells. This is basically blood, diluted blood, of course, 90% diluted. So you have cells coming in and the sheath fluid compressing the cell stream and allowing it to pass through this tiny channel. And the size of this tiny channel is just slightly bigger than the size of the cell. I think, for example, the neutrophils, for example, they are 20 microns or 15 microns, and this is just 20 microns or 25 microns. So the hydrodynamic force is coming from either side. It's going to push the cell and compress it. Do the same thing that was happening with the tomatoes, right? And there is a region of contrast. We have a high-speed camera taking taking pictures at 10,000 frames per second. And this is where we analyze the cells. What are we analyzing? So what you saw with the tomatoes was that you had, let's say, a very simple example of a circle, equation of a circle. What would happen if you compress the circle? It's deviation from the circularity, right? So 1 minus p is the deformation. Very simple idea. Still goes into nature methods. We don't know why. So anyways, so here is a real-time video of software. On the y-axis is the deformation, that is 1 minus this equation, and the x-axis is the cell size. So you get, this is, by the way, HL60 cells. The plot, what you see here. So it's a bit difficult to, but you try to focus on this area. There are cells passing through it, but I hope next slide will supplement this thing. So real-time deformability cytometer, for example, this is cells are going to pass through that region of interest really fast, and it's going to categorize the cells just based on y-axis deformation and the x-axis cell size in 3 different populations or 4 different populations. This is the red blood cells, and these are the lymphocytes. These are the granulocytes, myeloid cell fraction, granulocytes and monocytes, and these are the platelets. So you can see that just by taking images, applying this small equation. But of course, by the way, somebody was talking about here that, or I think Dr. Chirag, he was talking about what kind of hardware do you need? You just need a simple computer, simple home computer for these calculations, if you have the code. of course. So changing gears a bit, I said initially that first of all, you analyze the cells, and in the second run, you have to isolate them. So what you have in your hand, you see that there are gold electrodes deposited on the surface of this substrate. And these gold electrodes are basically going to produce small tsunamis. You remember in 2008, there was tsunami, and the pressure wave pushed everything away and it took everything away. We are going to produce the same tsunamis, but in a very, very controlled manner. For example, here, you have a piezoelectric substrate, and when you give sound waves, or sorry, you give sinusoidal signal to it, it produces sound waves on the surface. You cannot see them, but they're very tiny sound waves. These sound waves are responsible for pushing the cell. And taken from Wikipedia, when you have two sound wave producing sources, and they are so adjusted that they produce constructive interference that results in the pushing of the cell, or taking the cell from the pressure node to the pressure antinode. I'm not going to go into the math right now. So the device that you have right here, if you take a cross section of that device, this is shown right here. And let's say you remember those sheath fluids that were focusing the cells exactly in the middle of the main channel. That is shown by this shadow. And as soon as the sound waves are turned on, the pressure waves are so adjusted that the pressure antinode forms not in the center, but slightly off center. And with that split of a second, the cell is pushed towards pressure antinode, and that results in the cell going in the sorting outlet, or sort outlet, or sorted cells. And that is because this bifurcation, this small animation will explain everything. The cells are coming in, they're flowing in, and as the region of interest detects a cell of interest, for example, in this case, the blue cell, as that happens, it gives a signal to these gold electrodes that a cell of interest is coming, and push that cell in the sorted outlet. You collect that in another while. And I won't go into the details of the engineering background of this, but these devices, they are produced in the clean room, both the top surface and the bottom one. Interesting part for all of you people is the cell imaging and the sorting results. Starting with a very, very simple example, we just took two kind of cells, one big and one small. Over here, the axes are reversed. On the y-axis is the cell size, and on the x-axis is the deformation, so just keep that in mind. And I told the software that I'm going to put gates of cell size, let's say 75, and then deformation from 0 to whatever, 0.2, for example. And when that happens, I got a result of the cells which were initially 22%, they got enriched with the same devices that you have in your hand up to 88.2%. And there is a short video showing the same results. These HL60 mixed with KC167 cells. These are Drosophila cells, I guess. So I don't know if it's difficult to see, but the cells are going to the top default outlet. And as the sound waves are turned on, the cell of interest gets analyzed in this region, and the cell of interest is pushed down. By the way, this device, since it can analyze and sort 10,000 cells per second, what you were able to do in 83 years with atomic force microscopy, you can do it in 10 seconds. Just quick maths. Okay, so some quick examples. Let's say this is deformation versus cell size graph plot. Each plot here is the information that you get as the cell passes through the region of interest. So I gated the red blood cells, and from 49 point, but by the way, this is diluted, depleted red blood cell, red blood cell whole blood, right? And 49.5%, that it got increased to 96.6%. And in a second experiment, the 4.1% of lymphocytes, it got up to 89.1%. It's just showing you the proof of concept that what we have developed, it can sort very ruggedly the red blood cells and the blood cells, or even the tissue cells, for example. And the myeloid cell fraction, which is 43.2%, it got up to 94.7% approximately. By the way, this is these are just representative examples. The number of times you repeat this experiment, it's going to give you the same results. And even to this day, these devices are working in kinder clinics and in clinics in Germany, where we developed this device. And still they are doing side by side comparison of these these image-based cytometers with the commercial flow cytometer. Interestingly, if you have deformation versus cell size, initially I talked about these flow cytometers which can do 7-part differential, right? So, but our device can only do 3-part differential, or say 3 important populations: lymphocytes, granulocytes, monocytes, and then the red blood cells. But we realized that analyzing the image was not just limited to deformation. Just when we took brightness as a parameter, we got information about some hidden populations that could only be discerned when we had brightness come into the play. And the same populations that were initially hidden, for example, in this myeloid cell fraction, we plotted the same data for brightness, this arbitrary unit. The hidden populations, for example, these are the red blood cells. The black ones are the neutrophils. Then you have the monocytes. Then you have basophils. These are the platelets, thrombocytes, and then lymphocytes. So you have 7-part differential without adding any labels. So that means that the price of a single test or a single CP that Islamabad Diagnostic, for example, takes, I don't know, I remember it used to take 3,000 rupees for a single. It gets down to probably tens or 50 rupees, I guess. So there are no labels involved at all. So just a quick example, what we are sorting is without labels, but of course, like somebody just pointed out, you have to compare your results with the ground truth. Are you sorting neutrophils really? Then what we did was we sorted, for example, based on brightness versus cell size, we sorted the neutrophils, and then we did the ground truth analysis for that by labeling those neutrophils, and we found out that yes, they were really neutrophils. But this is a short video you can see as a talk. So all of this stuff that is happening, this stuff can we shift without doing the effort ourselves? Can we convert this all to the artificial intelligence? And that is where we are leading, and we were successful in doing. You remember the first video that I showed in the beginning, artificial intelligence. So artificial intelligence, I was using deep neural nets for this. And since this is not an artificial intelligence lecture, but when you have some hidden layers and more than 3 layers, it's called deep neural nets. I guess people, some of you from physics background know about this. So basically what we were doing is that we were taking a single image and then using a very 4-layer CNN, and then use that to analyze and sort the cells at the same time as well. So this software is, by the way, free of cost. It's up there on the GitHub if anyone of you wants. You can also characterize, for example, you can have a folder of dogs and cats, fruits, whatever, and you drag that into the software. It will automatically characterize whether these are cats, dogs, horses, whatever, right? But we use that for cells, of course, in our case. This is, by the way, supervised learning. Supervised learning means that we tell the software that these are the neutrophils, we draw a gate around it, and then we tell the software that these are the lymphocytes, myeloid cells, or whatever, platelets. And then it can, and important thing was that using the artificial intelligence, or to be very particular, these DNNs, you can see that we got a ground truth accuracy of 95.5%. And that was something that was very remarkable. And we were very happy about this. Not only that, but we were able to do all this comparison and also giving a feedback to the downstream sorting unit within 200 microseconds. Because you have to analyze the cells and at the same time, in a very fast manner, also give a signal to the downstream that the cell of interest is coming. Please give a shot and then push it to the target outlet. This is an example of hematopoietic stem cells. And since this is a talk about nuclear medicine, and when we talk about nuclear medicine, we have to talk about cancer, right? So what we were doing on every Thursday, we were taking bone marrow from human patient, of course, with the consent. And then we were centrifuging it so that we got rid of all the gunk that is not required. And if I'm not wrong, you can correct me if someone has more precise information, but I'm told that the stem cell is one out of sometimes 10,000, 1 out of 10,000. So we were able to enrich those stem cells using our device that you have in your hands by 0.012%. This is after centrifuging, and we got an enrichment of 92.2%. And we also did the ground truth comparison because we realized that in between the lymphocytes and the granulocytes, monocytes, this region, very small region, was the region where the stem cells were lying. And by the way, just for your information, in Germany, when a child is born, you are asked to fill a form where you know, this umbilical cord that is connected to the child and the mother, it is very rich in stem cells. And you're asked to sign a form if you can donate those stem cells for, you know, research. When I had my first child, I said no, because I was not aware of what was going to happen. But since I'm in science and I like to contribute more, I realized that when I had the second child, I said yes, because I wanted to donate the stem cells in that umbilical cord for research. So we did the ground truth comparison. Where is that? Sorry. So I think that slide is a bit missing here, but we did the antibody test with these stem cells, and these were actually stem cells. What we did was we transplanted those stem cells in a gamma ray irradiated mouse. And after 4 months, we saw that the bloodstream of the mouse started producing the red blood cells, which were coming from human lineage. That means that the stem cells were homing into the bone marrow of mouse, which was gamma ray irradiated, and we were successful. That means that we were sorting the stem cells, which are considered to be very, you know, fragile cells. We were sorting them not even effectively, but we were also sorting them without affecting their proliferation rate, right? And another example was the transplantation, the same device that you have in your hands. We used the same device for transplantation of rods that are the photoreceptors in the eyes. And of course, we cannot use human subject in this case. We used mouse and then transplanted very successfully in another mouse, which was able to see and find its way through the maze. So this was, you know, actually liked a lot by the local newspaper and stuff like that. But interestingly, for recently, although we have passed through the corona, you know, era, but I had some interesting results with the same analysis using artificial intelligence, that if you have deformation versus the cell size, the red blood cells of the healthy patients, they have a distribution right here. And the one with the corona, and this was after two weeks, that the red blood cell, the deformation, it spreads, look at the median value of deformation, it spreads a lot. And then after recovery, even though they are quite back, but still there is a spread of, so that could be a possible reason, because red blood cells are bringing in oxygen. And you realize that if any one of you got corona, I did as well, that I felt lethargic, and that could be a possible reason, that the cells are still quite hard, right? On the deformation scale, they are spread out. The harder the hard cells, or the more stiffer cells, they have difficulty to go through tiny veins. That's just a physical approach how to see those things. And since the red blood cells are bringing in oxygen, so that means that you would feel lethargic, and that's how I felt as well. Let's study the neutrophils. But neutrophils have a different game. Initially, the healthy patients have a spread of deformation versus cell size right here. And then the recovered COVID-19 has a larger spread. And that means that the cells are becoming more deformable. And you guys can tell me better, because I'm not a medical doctor, but I was told that sometimes it happens that the neutrophils, they go and cluster into the lungs. And that this could be a possible reason that the person cannot breathe, because the neutrophils go and fill up the lungs, and then the neutrophils are, you know, blocking the lungs, and they sometimes become permanently damaged, I've been told. I'm not too sure about what is the medical background of that, or medical standing of that, but
10 minutes.
yeah, almost done. So this is the recovered patient after 6 months. And then these are the lymphocytes. They remain more or less same, but still there is a spread of the median deformation values. And these are the monocyte values. I'm not going to go into the too much details, but with that, I would let next 10 minutes for question and answers. I would like to thank the technical committee, Dr. Hasnan, for inviting me basically at this platform. And of course, I cannot forget all the platform that I've been provided by PNS, right, Pakistan Nuclear Society. Thank you all, but I cannot, of course, close this talk without thanking the group that I was working with, sorry. And that is my director of Max Bank, that's Johan. And as you can see, he himself is also inside the wheelchair. And that was the basis of what brought him into this research. A big group of his is working on neuron generation, because when he was 19 years old, he got into an accident and his lower part is not functioning, even though his legs look very normal. But you know, those things happen, and in the West, they push people towards that direction. So he's one of my big role models for life. With that, I thank you all for your patience. Thanks. Any question, please? Questions? No question. Yes. Thank you.
Assalamu alaikum. It was a nice lecture, though I was not able to attend it all. Dr. Nazir, I'm from NUMS. I would like to know, you talked about stem cells and its use in cancer therapy. What are the chances of use of the stem cell and therapy of different types of cancer? Because they got the ability to differentiate in any form of cells.
Right. So I think this is more of a topic of reverse engineering of cells. We know that we were working only with the hematopoietic stem cells that would differentiate into the red blood cells. And what our aim is that we took those stem cells that were sorted with our device. We tested on, like, let's say 15 or 20 mice. We injected the human stem cells into NRI mouse, which is gamma ray irradiated mouse. And then we were able to see that the cells were homing into the bone marrow. And then when we took the blood of mouse after 6 weeks and then used human antibodies to it, and then we found out that the stem cells that we sorted from humans and transplanted into the mouse, it was able to produce human red blood cells. That means that it was differentiating without any problem those stem cells from human. Of course, this is West, and we cannot try, even here, I think we cannot test without going into the FDA approval of these practices. So we hope that someday, let's say this device got patented very recently. In fact, I think just 3 weeks ago, the patent was awarded. So I hope that this work will lead to personalized diagnostics, personalized therapeutics, I would say, that we can, have stem cells or stem cells extracted from bone marrow of a certain person, and after sorting, enriching them, retransplant in the same person after analyzing that nothing is wrong, or it can differentiate or proliferate in the right way as medical doctors would suggest. So I hope that answers your question. I think there's still quite some time that FDA approval will be received, I think, because I'm now here and I just don't have connections with them as frequently as I could earlier. Any question? There is a question there.
Assalamu alaikum. I am Dr. Khalid Mahmood from Ahmedabad University of Science and Technology. This is indeed, I could see great promise for identification of the long COVID, which is actually a great problem still going on. And there is a lot of research about identification of long COVID. But I think this promise which you have done with this deformability flow cytometry, this is somewhat more practical. And if I can say that it can be a lab or bench or bedside solution to this with the instrument or with the chip you have distributed here. So do you see this promise coming through in near future for long COVID or any other potential viral or bacterial disease which is coming?
I think that's a good question. And the promise is kind of in the West, it's kind of being realized at this moment as well. I would suggest you can, there is a website, Zell Mechanics Dresden, ZELL Mechanics in German, and Dresden. That is a company that was founded by my boss. He sells this equipment. Still not very cheap. It's like 130,000 euros. But I can tell you that a part of his team is working to reduce the price to 30,000 euros. Right, so there is still 1/3 of chunk being taken away, and I think that's not bad. That's not a bad start. And talking about bedside, I think the size will be the size of the printer. I'm talking about that unit, which can, which is like 30,000 euros. That is just the size of a printer. But I think it cannot sort at this point. It can only analyze. Right. The sorter is always expensive in fact.
Last question.
I have these devices, and if someone is interested to work, I would be more than happy to collaborate.
अस्सलाम वालेकुम।
वालेकुम।
मेरा क्वेश्चन ये था कि जो सॉर्टिंग डिवाइस है हमारे पास, अगर फॉर एग्जांपल बहुत कंसिडरेबल साइज डिफरेंस है या मॉर्फोलॉजिकल डिफरेंस है, तो क्या सिर्फ तभी सॉर्ट करेगी, या अगर फॉर एग्जांपल कोई हमारे पास जैसे किसी वायरस के वेरिएंट्स हैं और उनके ऊपर बहुत इनकंसिडरेबल सा डिफरेंस है मॉर्फोलॉजी में सबकी, तो क्या वो सॉर्ट आउट हो सकते हैं?
Very sure your background is physics, I guess.
No.
No, what? It's medical?
Biotechnology.
Still, okay. जो ये डिवाइस है, we have designed it in such a way, इसके ऊपर जो गोल्ड इलेक्ट्रोड्स हैं, उनकी एक फ्रीक्वेंसी है, और हमने उसको यूनिवर्सल फ्रीक्वेंसी पे रखने की कोशिश किया, so that it can sort small cells as well as very big cells, right? Coming to your example, हमने कुछ cells sort किए थे, the red blood cells, because these cells are being allowed to pass through a very tiny channel and they get stretched, right? And when they are stretched, just like आपने वो गुब्बारे देखे होंगे जो बाजार में बेचते हैं, गुब्बारे के अंदर एक और गुब्बारा होगा. So basically the same analogy, the red blood cells have this malaria parasite in it. So when we stretch that, we could literally see the parasite and still sort the cells which have parasites in them. So it's so sensitive to imaging. So if I hope I have answered your question. You
Say
can
there
sort,
are 4 cells.
yeah, you can sort from platelets,
Mhm.
and you can also, I don't have examples over here. You can not only, अगर एक बड़ी सी population है, starting from let's say 10 microns to 50 microns, you can even take out a small slit of size.
On the basis of size only.
No, size, definitely, there are 10 different parameters. Cell size, deformation, then you have the aspect ratio, A to B, right? And then you have the brightness, standard deviation of brightness, right? And then granularity, जो flow cytometer में side scatter होता है, basically. And then keep in mind, ये जो flow cytometer है, it does not give you an accurate size-based sorting, right? It's just a shadow effect of size. But this gives you exact size because you're taking images of cells. So there are 10 or 11 different parameters, including fluorescence. हमने इसमें fluorescence भी ऐड. जो आपका question था अभी कि जो state of the art 130,000 euros वाला है, उसमें flow cytometer, real flow cytometer plus image based flow cytometer plus cell sorter, तीनों चीजें मौजूद हैं. So you have all the capabilities of commercial flow cytometer, then imaging flow cytometer, and then the deformation based flow cytometer. So there are 11 different parameters other than cell size. Cell size is just a very small thing. It's just a very minuscule thing. अब देखें जो आपने वो brightness और उसका plot देखा था, उसमें बहुत सारे cell sizes बराबर हैं. So if you have just, you can give multiple parameters at the same time, deformation, brightness, you can just fish out the, for example, neutrophils. Neutrophils or, for example, monocytes का roughly अगर same cell size है, you can fish out monocytes even though they are slightly different in cell size.
Thank
I
you.
hope you have answered.
Thank you, Doctor.
I am.
Thank you. Other quick question, if you want to any question, then you, and during the lunch break, you can ask. Now, next speaker is Miss Noreen Marwat. She is medical physicist in Atomic Energy Cancer Hospital, Nuri. She did a master in medical physics in 2006. She joined the Nuri in 2007, and she is responsible for quality control of equipment and taking care of patient and staff safety. She is also IAEA expert medical physicist, and also she worked as a visiting faculty at PIAS from 2011 to 2015. She is offered many research projects to medical physics students in medical physics and nuclear medicine departments. Supervised numerous medical physics theses from PIAS. She is also visiting faculty of the University of Health Sciences, Lahore, from 2011 to 2018, visiting the faculty and external examiner at University of Health Sciences, Lahore, Rolpity Medical College as a imaging in imaging technology. The topic of the Ms. Noreen is personalized nuclear medicines dosimetry. Dr. Ms. Noreen.
Assalamu alaikum and good afternoon to everyone. Sorry for the interruption. Assalamu alaikum and a very good afternoon to everyone. Thank you so much, sir, for the nice introduction, which I don't really deserve this much, but I'm so honored and so happy, glad to be here. Thank you, the organizing committee and people from comstech for giving me this opportunity to be here. You guys already had a brief introduction about me. I am a medical physicist by profession and working at Atomic Energy Cancer Hospital, Nuri. The topic given to me is personalized nuclear medicine dosimetry. Before starting with before starting with the actual topic, I would like to briefly tell what actually nuclear medicine physicist does, because we are physicists and we are working in a medical center. So for some of you, maybe this is something which is new, or maybe you guys are not that much familiar with what our job is actually at the medical center. So in nuclear medicine department, medical physicist has a vital and challenging role. How challenging? Because what we have to do is we have to work with a multidisciplinary team. We have to work with the nuclear physicians. We have to deal with the technologists, radiopharmacists, and nurses. So these are all the team members, including us, the nuclear medicine physicists, who are dealing with who are working in the nuclear medicine department. I'll briefly go through the roles and responsibilities which we have in our department. So first of all, whatever equipment in nuclear medicine department we have, we are the one, the physicists are the one who are in collaboration or in with the nuclear physicians. We are the one who decides which equipment we have to buy. We are the one who are defining the specification. The word specification means we need to see which equipment and what characteristics of the equipment should be there, which we are supposed to buy. So we need to manage the equipment, and we give specification for the equipment. And once the equipment is arrived, then we have to check whether they fulfill the specification. That is known as the acceptance testing. So that's again another job of the physicist. Once the equipment is in the department, we have to make sure that it's working according to the requirement, because this is something, this equipment is something which is catering the patients. So we have to make sure that this equipment is working according to the requirement or not. So there are many checks. Some are being performed on daily basis, some are performed on the weekly, and some are on monthly basis. But we have to perform those checks. Then there are lots of data acquisition when you have equipments. There are lots of processing with the data in the nuclear medicine department. So we help the people, the other team who is working in the department in processing and acquiring that data. And research and development, as you have already heard from sir, that we are also involved in the research, as we have students coming up in the department. So they are doing research projects as well, and plus we are doing some research on our own as well. Teaching and training, of course, we are associated with CAS as well, so we are training physicists, nuclear physicians, and oncologists at our hospital. Patient handling skill, because in nuclear medicine department we don't have like the patients are not the ordinary patient, ordinary in a way that we give them radio pharmaceuticals, we inject them with radionuclides, so they become sort of a source of radiation. So they have to be handled in a specific way, and that's what our job is to tell them to how to handle those patients, especially the ones who are injected. And when it comes to radiation and handling the patients with the radioactivity, of course, radiation protection is our main job at working in a nuclear medicine department, where because we are dealing with the radiation, so there are staff working there, there are patients, there are people who are just coming with the patients. So we have to make sure that everyone is safe from the radiation, which is there in the department. So the topic is dosimetry, personalized dosimetry. So dosimetry means that we need to measure the dose, whatever dose you are giving to the patients or whatever dose you have, you need, when you are measuring that becomes dosimetry. Nuclear medicine department briefly deals with the two, maybe you have already gone through the lectures or presentations, that it mainly caters to part in a department. They cater the diagnostic part as well as the therapeutic part. So maybe if I'm not wrong, roughly 70% they are dealing with the diagnostic part, and 30% they are dealing with the therapeutic part. So in diagnosis, the main difference is that in diagnosis, from the medical physicist point of view, in diagnostic nuclear medicine, they give lesser doses to the patients, and in therapeutic nuclear medicine, they are giving high doses to the patients. And these are some of the nuclides which are being enlisted here, which are being used in the department. There are many more as well, but these are the ones which we are using in our department for radionuclide therapy. Okay, see, dosimetry, and there's a patient who is coming by choice or by requirement for a radionuclide study or a scan. So why do we need dosimetry for that patient? We have to give radiation to that patient. The patient has to be exposed to that radiation. And the question comes, why do we need dosimetry? Anybody can answer? Not the nuclear physicians, because I know they can answer better than me, but anybody else from the students or see, there's a patient who is being advised by the doctor to go and get this test, right? So we have to give them some activity to perform that test. Now, why that patient has to go through dosimetry? Anybody? Okay, no problem. Oh, yes, sir. Exactly, yes, because how much dose we have to give the patient? So there must be a minimum dose and there must be a cutoff dose. We cannot compromise on the safety of the patient, because remember, you are dealing with the radiation. So you have to limit the dose, how much optimum dose is required for the patient to be examined. Like, of course, see, आप activity दे रहे हो patient को, inject कर रहे हो, या you are administrating activity into the patient, आपका image जो है वो higher dose के साथ भी you will get the image, you will get a dose with the optimal dose as well. But नुकसान किसको होगा? Who will be at the loss end? The patient, because he or she is going to be exposed with a more amount of radiation. For that, we need to see what was the optimal dose, how much the patient has benefited from the dose, and how much we have like exposed the patient. Because आप जब कोई study करते हो, you inject pharmaceutical or you give pharmaceutical to the patient, it is going to deposit in certain organ, right? But the body has multiple organs. So if one of them has activity deposited in it, suppose in liver, what is next to liver? Kidneys, heart, lung, everything will be exposed, because सारे का सारा जो activity है, radiation है, वो उस organ के अंदर जाके disappear नहीं हो जाएगा. It will start emitting radiation, and some will go into the lung, some will go into the heart, some will go into the kidneys. So we have to make sure that they should not go beyond a tolerance limit or a safe limit. For that, we need dosimetry. The slide says, of course, I have written it, the future's essential need, but I think it's not the future's need, it's the time's need. Okay. A common practice. I'm not going to say that everybody is following that practice. A common practice means a general practice in nuclear medicine department across Pakistan. I would say that there is one size fits all formula. Like you have defined activity levels for different studies. For this study, suppose for some XYZ study, I have to give 700 megabecquerel. And for another study, I have to give 300 and so on. So one size fits for all means a patient comes for a specific study and we give them that amount of activity. And another practice is a bit modified, that they see the patient, they see the body weight of the patient, and they add amount of activity in it. Like suppose if 700 is prescribed for an average man, if a thin lean man comes, they will reduce a bit, and if they will a bit obese person comes, they will add an amount of it. So this is another practice. Now, what happens if you are going to practice like this? Definitely, you will get some results, but maybe the patient you will be overdosing the patient or underdosing the patient. So for that, I think you need to see how much actual that person requires the dose. There is a book written by Michael G. Stabin, and in his book, in chapter 8, he mentions a very nice thing, that in the regulation requirements, you may measure doses for radiation workers. Like I am a radiation worker. I have a dosimeter with me when I'm working in the department, which is measuring my dose. All of the staff, their dosimetry is being performed, that either they are exposed to more amount of radiation or not. When you go through the CT scans, you measure the dose of the patient. You don't want to overexpose the patient. Then we have radiotherapy, where you treat patients, cancer patients. Again, you check the doses to the tumor and you check the doses to the organ. And even for the airline people, for the pilots, for the flight attendants, you make sure that they should not cross beyond a safe limit of doses. The only people on this earth are the ones who are ignored from this is the nuclear medicine patients, right? This is when he wrote the book. Now people have started working on measuring doses. So again, in radionuclide therapy, you give higher doses, and of course you come up with the deterministic effects as a result of higher doses. And what your aim is, you want to cure patients. And for that, you need certain protocols, how much dose you have given to the patients, what is the legal requirement, because in some countries, it has a legal requirement. The regulatory body, they intervene. They should not exceed this much amount of radiation when they are administering it into the patients. Optimization means how much is required. Because if you are giving more dose, you will have a quicker study, but whether it is required or whether it was needed. And again, when the patient comes for a follow-up, patient should not land into toxicities or complications. This is what the radionuclide therapy objective is. And when it comes to patient-specific dosimetry, I'll just quickly go through it because it's a bit complicated procedure, but I will give you an idea how it is performed. So activity is administered to the patient and it distributes over some time into the patient's body. It goes mainly, it accumulates in the organ where it is being labeled for, and in rest of, and it is being deposited there, it retains there for certain time, and then with the time it decays. And at that time, of course, when you are, the activity is there, it is going to expose rest of the body and its organs. So we need to see how much the rest of the body or rest of the organs are receiving those doses. And for that, there is a calculation model or formalism which was developed back in 1960s somewhere, and that is MIRD schema. MIRD schema is the Medical Internal Radiation Dose Assessment Committee. They have defined some formalism for the assessment of the dose, and this is the general formula. If you see, it is the dose received by an organ is basically a product of two terms, where you have A and S, where A is the cumulated activity which an organ is receiving, which you want to measure the dose for. And S is basically how much absorbed dose that organ has received from the source. Oh, okay. So this is the flow chart for the MIRD methodology. आपने पेशेंट को इंजेक्ट किया, पेशेंट के लिवर में चली गई है, आपने मेजर करना है पेशेंट के किडनीज को कितना डोज मिला है. व्हाट यू हैव टू डू इज, आपने एक को सोर्स ऑर्गन बोलना है, एक को टारगेट ऑर्गन बोलना है, राइट. सो सोर्स ऑर्गन इसमें बनेगा लिवर और टारगेट ऑर्गन बनेगा इसमें किडनीज, राइट. समटाइम्स source organ target organ भी हो सकता है. The reason is because it is self-radiating itself as well. Then how to determine A? That is the time activity over the time. You need to see the cumulated activity over the time. And then the other is the S factor. There are tables as well. You can look up for the values from those tables. They are model-based studies, but comparable to the human anatomy. And then by the product of two, you can determine the dose, and you take the sum if you have more organs, and that will be the total dose received. Again, same thing, because I'm short of time. This is how you are going to determine the cumulated activity over the period of time, this curve, and how this is being, this curve is being achieved. You have to image the patient with respect to time, and you have to plot this graph. Now, the question comes, actually, I was supposed to ask this question from you guys, but we don't have that much time. So the imaging is very much similar to the one which is being routinely performed in the department. If you see this curve, it's a very interesting curve. You can see the points on the curve. These are 6 time points, and there's basically 6 times patient is being imaged on the scanning camera, and you have okay, and you have you attain the time activity plot. But remember, 6 time patient के लिए मुश्किल होता है. पाकिस्तान जैसे मुल्क में आप 6 time patient को कॉल करोगे कि भाई कल दोबारा आओ, 2 दिन बाद दोबारा आओ, it will be difficult for a patient. So what we do is we reduce the time point to 3, and but selection of time point is important. This is very much acceptable, but this is not acceptable. And this is how we calculate the absorbed dose. So the thing is, because I need to wind up, that you have to measure dose by taking these 2 parameters for every organ, and you have to find out the tolerance doses, that you should not exceed the tolerance doses of the organs, so to keep your patient safe. And next time, for the next time as well, if the patient comes next time, you should make sure that you have exceeded the tolerance or how much window you have, and you can give activity to the patient. We have a software, but I think we are short of time, so thank you so much for your time. Thank you.
If you have any question, you may contact her during the lunch time. Now, the final third speaker of this session is Dr. Nadeem Ahmed Lodhi. He is a principal scientist at the Pakistan Institute of Nuclear Science and Technology, comstech. He completed his MSc in Nuclear Engineering from Pyas, Islamabad in 2009. Later on, he pursued his PhD degree in nuclear medicine from Seoul National University, South Korea in 2019. His current research focus on PRRT. He has more than 10 international papers published in prestigious journals. Dr. Saab, you have time for 15 minutes.
15 minutes is very less, I think.
20 minutes, okay.
Okay. Assalamualaikum. Thank you for giving the opportunity to talk in front of this audience. So straight to the topic, actually we have a short time. So my name is Dr. Nadeem Ahmed Lodhi. I am a principal scientist in comstech. So today's topic is the theranostic from bench to bedside. So before this is the course outline of my presentation, the overview of the comstech activities that we are doing, a little bit about theranostic, and because a lot of being talked, it's a hot topic, theranostic, so I will give an overview of that what we are doing at comstech, the preparation of lutetium dotatate and QC method, and finally, I will discuss two cases that we have treated with lutetium dotatate. So comstech is a Pakistan Institute of Nuclear Science and Technology. It has two research reactors, PAR 1 and PAR 2, and PAR 1 is got into the critical in 1965, and we have another reactor which is a miniature type of reactor which got critical in 1989. So these are technical actually parameter. It's a pool type reactor, PAR 1, and PAR 2 is a tank in pool. So these are the properties and technical data. I will not go into the detail, just give a review. These are because comstech is the only producer of reactor-based radioisotopes in Pakistan, and which provide to all the medical center, to the PEC and the non-PEC and the private medical centers. These are the few radioisotope which are mainly iodine 131, technetium generator, and few kits which are MeB, DTPA, DMSA, phytate, MDP. These kits are supplied to all the nuclear medicine center in Pakistan. These are the radiopharmaceutical which are in clinical development, and we have done a lot of work, and few of them are under these kits are all registered into the DRAP, so there is no issue regarding the regulation on supply of these radiopharmaceuticals to the medical centers. These kits are under, and radiopharmaceutical are under evaluation at the drop, so we only supply these radiopharmaceutical on research and development basis. These are other radiopharmaceuticals which are enter into the clinical, into the research phase at our institute. So this is the moly plant, production plant, which produce the moly, fission moly, because we have this facility of production moly 99, which is obviously used for the production of technetium 99 generator. And there is another isotope. We have iodine 131 plant. So this is just only giving an overview. Theranostic is actually basically the combination of therapy and therapeutic and diagnostics. So we can use one radiopharmaceutical for diagnosis, and the same drug can be used for the therapeutic as well. Or it can be the different radiopharmaceuticals for diagnostic and other radiopharmaceutical for the therapy. So for example, here in this case, if you see here, this is actually the emerging field.
The angle is very strange. This is actually emerging field in which the diagnostic and emerging field in which the diagnostic and therapy can be done with the same drug or which can be done with a different. For example, here you can see the case. This is a lutetium dotatate and the gallium dotatate. The one is used for the therapy, and other one used for to monitor the response of the therapy. So these are the theranostic pair, which are can be used for the diagnostic as well as for the therapy. So mostly this gallium and technetium and used for diagnostic, and lutetium is used for therapeutic purpose. So these are the radionuclides with beta emitter and Auger electron and alpha emitter they can use for the treatment and radionuclide therapy. So basically, lutetium is an important radionuclide used in the therapeutic applications. It emits very soft beta particles with the energy of 489 keV. It emits also the gamma rays of 208 and 211 keV energy. So it can be used for the diagnosis. It cannot be used for the diagnostic, but you can use it for the imaging. But obviously, it can use for therapeutic application because it emits beta particles. So there are two different methods for the production of lutetium. The one is called the direct route, and another one is called the indirect route. In the direct route, we used actually this method. We used the direct production method. We utilize for the production of lutetium at the Pinstrick. We have 10 MeV Power 1 Pakistan Atomic Research Reactor. So we produce this radioisotope here at Pinstrick. So we use the target, enriched target of lutetium 177, 176. We irradiate it by using N gamma. As a result, lutetium 177 is produced. And obviously it decay with a beta particle to the hafnium, stable hafnium. So there is another actually impurities which is produced inside this lutetium 177 is lutetium 177M, which has a very long half-life of 160 days. So, however, this impurity is produced into the sample is very less, is less than 0.01%. So it don't affect too much, like because if you have a thermal to epithermal flux is very high, thermal flux is high. So this quantity, lutetium 177M, is produced in a very less quantity. So there is another method which is indirect route. This direct route method is called carrier added specific activity lutetium. However, with this indirect route, we have lutetium 177. We use the target of ytterbium and we irradiate it, and then we get into the lutetium 177. However, this method, indirect route method, we need a lot of separations, and it is very difficult to obviously separate because they having a same chemistry, ytterbium and lutetium having a same chemistry. So it will be very difficult to separate, and there are resins available which are obviously is not available here, and we are facing difficulty on the procurement of these resins because they use for the separation of lanthanide and actinide and so on. So due to restriction embargo as well. So we are using this method for the production of lutetium 177M. We are working on it. Maybe sooner or in the coming years, we will be able to produce lutetium 177 and non-carrier added one as well. So the theoretical specific activity, if you talk about the higher the specific activity, much better is the radioisotope. So in case of lutetium 177, we have a specific activity of 110 curie per milligram. So by using direct method, we can able to achieve, if we have a reactor of flux of 10⁻15, we can have a specific activity of around 70 curie per milligram. So with the medium flux reactor that we have at Pinstrick, so we can able to produce up to 20 curie per milligram. So in case of indirect method, we can have a specific activity close to the theoretical specific activity. So this is the only limitation we have, that we are actually producing lutetium, although, but with low specific activity. So until now, we have produced 17 batches of lutetium-177, and we have actually target enrichment is 74%. We tried to get the high enriched target, and we approached to the IAEA, and they helping us out to get this target of more than 90% enrichment. If we have that target, so we can able to achieve the highest specific activity. So we able to achieve until now the specific activity of 30 MCI per microgram at the time of bombardment. And we check the radionuclide purity is 99.9%. And then we have a radiochemical purity of 99.9%. And which impurities, which is only inside the sample, is lutetium-177M, which is less than 0.01%. So that is acceptable, as mentioned in the guideline as well. So this is the guideline which is published in IAEA ENM. This is a joint guideline which is in 2013. What they said, that higher neutron flux able to produce activity of greater than 20 MCI per microgram. However, at the time of labeling, it is around 15 MCI per microgram, but it should not be less than 10 MCI well injected into the patient, which is in our case. So we able to achieve that much specific activity, and then we went to the to test this lutetium 177 for the clinical that we can able to use, or how much the outcome of this study will be. So neuroendocrine, we selected the patient which are neuroendocrine patients. So neuroendocrine is a special type of cells which are present in the neuroendocrines, and especially the lungs, appendix, intestine, rectum, and pancreas. So these DOTA-TATE, DOTA-TOC, and DOTA-NOC can be used to target these neuroendocrine cells. 3 minutes. So molecular imaging which we used for these are the gallium DOTA-TATE, FDG, MIBG, and these FDOPA and tryptophan as well. Hynictate is also available, which we produce indigenously at our hospitals. So I will go through all the slides. I will directly go, and obviously Dr. Adnan Saeed has yesterday talked about this. I will not go into these details. And so we start the preparation of this lutetium DOTA-TATE by using manual radio labeling. So we have the precursor, we have the buffers, and we add into the vial. We adjusted the pH, and at the end of that we heat it, and then we get the lutetium DOTA-TATE in high purity. And few hospitals, they have automatic synthesizer like in MOL, and Kiran is also acquiring this automatic synthesizer, so they don't need to do the manual labeling because we don't have, so we do the manual labeling. And obviously this is very expensive as well, so acquiring the automatic synthesizer. So we do the quality check. The quality of lutetium DOTA-TATE is more than 99.9%. So it is we check the toxicity study as well. It is quite not toxic to the rabbits. So then we go ahead with the histopathology as well. So the cells are okay, fine. So they are not associated any toxicity associated with the lutetium DOTA-TATE. This is the specification. So we selected one patient with this neuroendocrine patient. So we developed this Hynictate kit as well, which is labeled with technetium-99M. So we did the baselines of this patient is so very high uptake and retention of the radiopharmaceutical technetium into the lesion sites. So then we did the administration of lutetium DOTA-TATE. Just only 1 minute, sir. So we injected this lutetium DOTA-TATE into the patient. This is the protocol we followed, and this is the one case study that we have shown the technetium Hynictate image. So it show very high uptake into the lesion. This is an image taken after 24 hours, and it show very high uptake and retention into the tumor site, and deliver the therapeutic effect to the tumors. So it show very good uptake into we have given 4 doses to this patient and the patient is feeling very well. Although his tumor is not that much regressions, but however, the complication associated with his clinical outcome is like his health was improved and he is feeling very good and stable. So this is another study. It show very high uptake into the lesion sites. So very high retention. This image is taken up after 24 hours. So background is very much cleared, easily excreted through the non-targeted tissues. So I will not go this one as well. So at the end, acknowledgement, I would like to thanks to the chairman PEC and Dr. Masood Iqbal, member science, Dr. Kamrul Haq, DG Pinstick, and Dr. Mohammed Wasim, Director Technology, as well as my team members. And at the end, obviously, to the Pakistan Society and Comstech and PSNMM for inviting here. So thank you very much.
Thank you. If you have any question, you can ask you during the lunchtime. And now at the end of the this session, fourth session, scientific session, now closing session will start at 2:15. Just one question. No, no time there. Yeah, 2:15 we will get here together. Okay, lunchtime on. Okay, thank you.
So welcome back after lunch. We are now going to start the closing session of this workshop. It will be having one technical talk, and we will again be encumbering our guest, Professor Dr. Abdul Hamid Al-Ghazar, to give a third talk. This is now on the topic of under-recognized bone diseases, role and pattern of scintigraphy. Am I right? Please. Where is the person who gets the talk? Where is more? Presentation. Huh? Presentation of the presentation. I have the payment anyway. Yeah, well, okay. No, this one. I gave you the. Thanks. No. Yeah. Okay, thank you again. And I hope you didn't get bored of me. My talk now is about my favorite subject, which is bone disease. And some of the conditions can be missed or misdiagnosed because they can mimic other conditions. So I'm gonna present some of those. And the first one is less frank fracture dislocation.
And actually, I met many of my colleagues. Some of them didn't even hear about it. Although it is not uncommon. It is injury, and sometimes the trauma is trivial. Or just you try to get the history of trauma from the patient and they deny because it is just overexertion or walking or some sort of a movement. And this is typically either happens in all the tarsal metatarsal joints, because as you see from this diagram, it's not really supported. That's why it's a weak area to be easily injured. Or it may only include just one or two of these joints. And if it includes all of them, it's called homo. And if one or two are involved, it's called isolate. It can cause a lot of disability. And when we continue, it's very important to remember in all bone diseases, the issue of referred pain. Some of these patients whom I saw with less frank, they came complaining of a hip pain. And that's why for the last 20 years, or maybe 25 years, we always use, and I am very keen about that, a whole body block pool. Because if you don't do that, you may not have the information from blood pool of a pathologic area that is away from the symptoms of the patient. This particular fracture or dislocation is difficult to diagnose even clinically. And also, it's commonly radiologically occult and may not be seen even by CT or MR. So scintigraphy actually is a very sensitive modality to diagnose this condition and is when you have the typical features or pattern, it's a diagnostic of this condition. Many times, it can be incidental and also it, because of the referred pain, you see it incidentally because it's away from the target area. Typically, you see increased blood pool activity in the region of the tarsometatarsal joints, and then you see the same in undelayed images. You can see here a couple of examples of the homo type of less frank fracture dislocation. And here is another case which again illustrates the increased blood pool increase the delayed activity. And for localization, you can see in the SPECT-CT better localization at the site of tarso-metatarsal zone. This is an example of an isolated type of this frank. And actually, this case was for a professor in the School of Science who came complaining of hip pain. And he had a history of bilateral knee replacement. But we found the reason is less frank disease. This less frank disease can be misdiagnosed as arthritis, commonly. So, for inflammatory arthritis, if you will. But if you have, or if you are aware of the subject and the location and the pattern, you put all together, you reach the diagnosis of less frank disease. Complex regional pain syndrome, or what we used to call reflex sympathetic dystrophy. It's a pain condition. And there are two types of complex regional pain syndrome. Type 1, which is the reflex sympathetic dystrophy. And type 2, which you are not concerned with. The difference is complex regional pain syndrome 1 or reflex sympathetic dystrophy. You do not have any major nerve damage. And as a matter of fact, the pathogenesis is not very clear. And again, this condition is under-recognized, misdiagnosed, and in the vast majority, it is diagnosed as arthritis. And actually, I have seen patients in several countries. They had a long history of pain and visiting physicians and so on because of the misdiagnosis. So we have to be aware of this condition. It's practically one of the high turnover diseases. And there is sometimes trauma, which is the most common. But this trauma could be trivial. I remember two cases very well. One resident in psychiatry, she was young. She was opening a jar of jam this way, and she developed the case. Another person was coming down on the stairs from an aeroplane, and he denied absolutely any trauma, because the patient, when you ask the patient about trauma, he will think falling down, accident, something like that. But trauma could be very unnoticed. But after talking to him, he said, one time I was coming from the airplane down and I was carrying it, and my foot just moved strangely. And after that, 3 months later, we diagnosed him, although in New York, he had MRI, CT scan, and all of this stuff with no result because of the private, interest and stuff like that. But the pattern was very clear. I'm not going to bore you with the pathophysiology, but there is still, it's not totally known But this triggering injury will cause imbalance between the nociceptors and the autonomic nervous system, the sympathetic and the parasympathetic. And this will lead to vasodilation. That's why, and increase the blood flow. That's why clinically we see warmth and the sweating, and on scintigraphy, we see increased flow and the blood pool activity. Recently, the immune dysfunction was added to the proposals of pathogenesis, but the fact of the matter is we don't know definitely what is the exact mechanism of developing the findings of the disease. But pathologically is known that these consequences will lead to some cell proliferation of the synovium and some fibrosis, vascular proliferation, all of this under the microscope, but no inflammatory infiltration. That's why this is not an inflammatory or infectious disease. And when this happens, of course, any injury or any changes in the tissue of bone will trigger new bone formation, which is the usual reaction of bone to any injury. And that's why we see increased turnover locally in around the joints, and this will lead to some resorption, and this resorption will be seen in the X-ray, like in this case. Don't know why I can't find the arrow is not working, but you can see on the right hand side of the X-ray some rarefaction around the small joints of the hand in comparison to the other one, which correspond to the findings on bone scan in the lower image. The bone scan is very instrumental in this diagnosis, as well as the follow-up, because many of those patients will get corticosteroid, and you need to follow up whether it's efficient or not. And the scintigraphic pattern depends on the duration, whether in the acute phase, in the middle phase, which is dystrophic, or atrophic phase at the end. And typically, you see increased, varying degree of increased flow, blood pool around the joints. It's a periarticular distribution. It must be periarticular. That's why it's being confused with arthritis. And you see the same on delayed images. This is the typical, and it may, most commonly, it affects the upper arm, particularly the hand. It can affect more than one area, like in this case, where the whole body scan here. You can see around the shoulder, elbow, wrist, and the small joints of the hand. It is usually unilateral. However, it can be bilateral in 7% of patients. So if you see the exact typical pattern, even if it is bilateral, it happens. It can affect the feet. It may affect all the joints of the hand, although it can affect isolated joints, like what we talked about, less frank, like in this case, it's affecting only 2 digits and the periarticular again distribution. The bone scan is really the most sensitive to detect this condition and help in making the diagnosis. I talked about the typical. Sometimes you see atypical, depending on, of course, the duration also. But even with the acute phase, you may see decreased flow on the blood pool with increased uptake periarticularly around the joints on delayed images in children. So this is atypical. And probably, because I don't know the exact reason, but I imagine the reaction of the children when there is some pain, they don't move. So it's like similar to the case with paralysis. So the blood flow and the blood pool decreases with the turnover finding of increased uptake around the joints on delayed image. In the late phase also, remember I told you about the atrophic phase. This doesn't show the typical pattern. It shows either normalization of the flow or blood pool or even decrease. And also on delayed, it may show trivial findings or even decreased uptake. So we have to be aware of these findings. The citadel from Cairo here. Sacral stress fracture. This is also difficult to diagnose and maybe underdiagnosed because the area is crowded and there is a urinary bladder as well when you look at the bone scan. That's why SPECT-CT again is important in this case. And why it's difficult to diagnose because low back pain and other conditions in the pelvic region are too many and with similar symptoms and signs. It can be fatigue fracture or kind of stress fracture, particularly in the volleyball players and runners, or it can happen commonly with osteoporotic patients. And of course, it's called insufficiency fraction. It can mimic other diseases. That's why it is difficult to diagnose. It is diagnosed by scintigraphy or MRI, and both are complementary. But scintigraphy is particularly useful, and you have a lot of patterns. The typical pattern is H-shaped, and I will show you that, 20%. But the most common is unilateral vertical uptake in approximately 32%. It can be also bilateral in the minority of cases. Here are the patterns in the diagram as well as in scintigraphy. The first one on the left-hand side is the H pattern. And you see that again in about 20% of patients. Sometimes you see two parallel lines. And sometimes you see one vertical and one horizontal fracture. Then the most common is you can see unilateral sacral line vertical. And you can see it also as one horizontal, which is more difficult even to find. The first image A, designated as A, it shows the H pattern, and you can see another trivial fracture lower down in the sacrum. The second one is the two vertical parallel pattern, and here is one vertical along with one horizontal. And here is the horizontal, and you can see how clear an SPECT CT with better characterization. Heterotopic ossification, and I'm not gonna spend a lot of time here because given the audience nature, but again, there is an inciting injury, usually trauma. And this triggers acute inflammation, not infection, acute inflammation. And this acute inflammation, along with genetic overexpression of osteogenic genes, because it doesn't happen in everybody after trauma. This will lead to dysplasia, metaplasia, sorry, with conversion of the stem cells to bone-forming cells. And this also will be helped with increased expression of some skeletogenic inducing factors, particularly bone morphogenetic protein 2, and under expression of the leptin, which is an antagonist to this skeletogenic inducing factor. So in brief, this will cause transformation of some immature cells to bone-forming cells. But if I say the pathogenesis is exactly known, I would lie. But this is a proposed theory. And it may be acquired or hereditary. The acquired is much more common, and it usually has benign course, but in about 10 to 20% of patients, it can cause disability, ankylosis, pain, disfigurement, and all of this stuff. Hereditary myositis ossificans progressiva is the relatively common one or more common, and the progressive osseous heteroplasia is a rare one, but it is one of the hereditary forms seen in pediatric patients. The cause of acquired forms are too many, but the trauma is the most common, including surgical trauma. Any patient who has hip replacement or knee replacement or any joint replacement is having a chance of developing this condition. And as I will mention, after hip replacement, the average of heterotopic bone formation incident is 50 to 55%. You see how common it is. And in many situations, it is misdiagnosed. Now, typically it is asymptomatic, but very importantly here in this slide, I will explain the phases of heterotopic bone formation or heterotopic ossification, if you will. Early on, it's called immature or inflammatory phase, which is characterized by increased flow and the blood pool. And this has actually inflammatory cells. And this is the problem in this phase. It can be confused with other conditions. Like in this case, this is a case of heterotopic bone formation, and actually it was misdiagnosed as osteomyelitis. Here is the follow-up of this case. And this is one of the values of the bone scan to follow up to determine the maturity, because the second phase, the mature phase, the flow and the blood pool decreases or normalizes or decreases and stabilizes. And this determines the timing of surgical intervention. Because if surgical intervention happens during the immature, it will aggravate the case with a lot of recurrence and so on. And to add to the complexity, yeah, I like to tell you here, this can be misdiagnosed as osteomyelitis, cellulitis, thrombophlebitis, even tumors, even thrombosis, and so on. To add to the difficulty, you have to be aware that other radiopharmaceuticals other than bone radiopharmaceuticals such as MDP, indium labeled white blood cells or technetium labeled white blood cells accumulate in the immature phase, but not significant. And this is a reason for diagnosis of infection or osteomyelitis. Gallium also has been known, as you see in the shoulders and the elbows of this patient. It can accumulate definitely in this disease. SPECT-CT, we published recently an article about that. It's a very helpful in localizing whether the finding is within bone or outside bone. These are the Kuwait towers. This is the last condition. You know, obesity has an impact on our practice, whether in radiology or nuclear medicine, because of too many reasons, particularly the attenuation in our case. And the steatopygia is one of the major reasons for pitfalls in bone skin. And it means a prominent fat in the region of the buttocks. And it may cause fat crease, but definitely it will cause attenuation. And here is a case. You can see on the left-hand side, attenuation of the lower lumbar spine. And it can mimic other pathology, including radiation effect in case the patient is a cancer patient and they had some. And the SPECT-CT also will help in visualizing the spine as normal without the attenuation. And the most serious pitfall, and actually in Mount Sinai School of Medicine, a professor misdiagnosed this nuclear medicine as metastasis. This is called the edge effect. At the edge of the steatopygia, there will be a scatter of the radio tracer, and they can cause one vertebra or so as a higher uptake than the rest of them. It's above the attenuation or the attenuated uptake in the lumbar spine, as you see here, the arrow. And the SPECT-CT is very crucial in these cases. I'm going to stop here. And I thank you again. Thank you for the invitation. I I really felt honestly the warmth of the colleagues, the generosity and the friendly attitude of all of you, and I appreciate all of this. Thank you very much.
Thank you so much, Dr. Hamid. It has been really a pleasure and an honor to have you here. And we look forward to having you here in the future also. Thank you once again.
Ladies and gentlemen, with this, we come to end of our technical session for this two-day workshop on advances in nuclear medicine and its application. In the technical session of sessions of this workshop, we have covered topics from diagnostics, therapy, imaging to AI. And with this, I would request Dr. Arzu Fatma, who is affiliated with Institute of Nuclear Medicine and Oncology, Lahore, to wrap up this workshop.
It is indeed an honor and a very pleasant duty for me to wrap up this workshop. On behalf of the technical committee, I am grateful to all the speakers and the participants for taking time off from their busy schedules to attend this international workshop. I would very briefly like to say a few words about each of the talks presented here. Starting with Professor Dr. Abdul Hamid Al-Ghazal. Sir, I will again reiterate that we are very honored to have you with us. Both his talks on the role of PET-CT in infection were very informative. In particular, the cases he showed, including PUO, infective endocarditis, COVID pneumonia, abscesses, etc. And in particular, the concept of the time frame of selecting the different options, including labeled WBCs, gallium-67, and PET for infection imaging is equally important. Similarly, his talk, this one that we heard right now, on the role and pattern of scintigraphy in under-recognized bone diseases was most illuminating and highlights the importance of these underrated conditions, including a Lisp-Frank fracture, though I have been working in nuclear medicine for quite some time, but either I've forgotten or it sounded like a new entity to me as well. And complex regional pain syndrome, types 1 and 2, sacral stress fractures, etc. Next international speaker was Professor Dr. Rehan Hussain. Sir, thank you very much for your presence. His talk was quite different and interesting because he initially chose to focus upon the history and culture of his country, followed by evolution of nuclear medicine. And finally, he showed us quite a few clinical cases having multiple primary malignancies seen on PET-CT. Professor İsmet Sarkaya from Turkey unfortunately could not join us personally, but her talk through video link on pathogenesis of cancer metastases was very conceptual, explaining the different routes of cancer spread along with self-explanatory PET images. Dr. Shazia Fatma, who happens to be a very dear friend and colleague, delivered 2 talks. Her first talk was on the status of nuclear medicine in Pakistan. She gave a very comprehensive overview of all the aspects, including the history of nuclear medicine, the institutions that we have in our country, the strength of personnel involved, including doctors, technologists, degrees and diplomas in the field, as well as the services being offered at different institutes in the country. Her second talk on PSA imaging was also very interesting, and besides academic details, carried her usual signature style with interesting comparisons and depictions like Barbie and Oppenheimer, etc. My own talk on PSA meta-diagnostics was an attempt on my part to familiarize you with both the science and practice of PSA meta-diagnostics. plus to share the theranostics experience from my particular institute, that is in Mole Cancer Hospital. Dr. Muhammad Adnan Said's talk on PRRT in neuroendocrine tumors was the last talk of yesterday's session. And though we were all of us trying with a lot of difficulty to stay awake, but it did capture our interest, Dr. Adnan, and you very nicely summarized all aspects of this therapy. Dr. Muhammad Babar Imran unfortunately had a road traffic accident en route to the workshop. Alhamdulillah, you saw him today on the video link. He's fine. His online talk on SPECT-CT was most comprehensive, and he shared his considerable experience in this field with us. Dr. Brigadier Mehdi Raza's talk on ischemic heart disease and management of chest pain was the much-needed change in flavor because it highlighted the importance of nuclear cardiology, and he did manage to show us 10 cases, which I believe covered almost the entire spectrum, though I wish that he had shown a case or two of global myocardial ischemia. Dr. Zahir Strak's talk on artificial intelligence in nuclear medicine was very captivating. It is important to become familiar with artificial intelligence and its uses in the field of medicine, because this is undoubtedly going to be the era of AI. Dr. Ahmed Esther Nawaz further elaborated upon this theme of AI in blood cancer patients. He kept us engaged with a lot of fun videos, though I must admit that most of the slides, including the ones on microfluidic environment and flow cytometry, were rather complex. Ms. Noreen Marwa delivered a talk on personalized nuclear medicine. It highlighted the importance of administering optimal dose to each patient, avoiding both under and overdosing. The last talk on theranostics from bench to bedside by Dr. Nadeem Lodi was very enlightening, though he was cut short because of time shortage, but this talk was very heartening at the same time. I'm sure lutetium-177 production at Comstech will turn out to be our next success story. This wrap-up would not be complete without mentioning the critical and supportive role of the following: Comstech Organizing Committee, Professor Dr. Muhammad Iqbal Chaudhry, Coordinator General Comstech, Professor Dr. Khurshid Hassan, Advisor Comstech, Dr. Muhammad Tahir Khali, President Pakistan Nuclear Society, Mr. Waqar Ahmed Butt, Vice President Pakistan Nuclear Society, and Dr. Shazia Fatma, President Pakistan Society of Nuclear Medicine and President Women in Nuclear Medicine Pakistan. I hope that we can rely upon all of you for your continual support for future such activities. Let us hope we all go away from here with one mind, that the best way to combat common problems, be it infection, inflammation, or cancer, is to work together. Thank you very much.
Thank you very much, Madam, for a very comprehensive snapshot of this workshop. With this, I would now request Dr. Muhammad Tahir Khalik, who is the President of Pakistan Nuclear Society. Pakistan Nuclear Society is a co-organizer of this workshop, for his concluding remarks, sir.
Bismillahirrahmanirrahim. Assalamu alaikum. Respected speakers, distinguished participants, ladies and gentlemen. It gives me a great pleasure to give concluding remarks in this important event. First of all, I want to convey special thanks and appreciation to Comstech for organizing this very useful workshop and giving an opportunity to Pakistan Nuclear Society and Pakistan Society of Nuclear Medicine for collaboration. I am confident that the learning experience in this workshop played the role of capacity building in this important area of medical field. I would like to appreciate all of you for your dedication and active engagement in the learning experience. Success of this workshop became possible due to the very experienced resource person for sharing their knowledge and experiences in their areas. This success is also due to the participants who have attended the workshop and enhanced their knowledge of this area. I understand that the topics that resonated in discussions here were use of latest tools and approaches. The presentations here show the need to adopt latest tools approaches and techniques for better medical diagnosis and treatment. Pakistan has vast experience in application of nuclear techniques in medical, agriculture, power generation, and industrial application. Pakistan may play a vital role in capacity building in these areas for other countries also. I hope this workshop will help us to shape our future capacity building activities. Let us assure that PNS will continue to facilitate capacity building activities with collaboration of comstech, government and private organization and education institutes. It is important if we establish an online platform where we can continue to exchange our experiences. During COVID, the online platform has already proved a very successful platform for such activities. By taking this opportunity, I would like to give a brief introduction to Pakistan Nuclear Society for the audience. PNS, Pakistan Nuclear Society, is a non-commercial, non-government professional body of highly qualified professionals, mainly scientists, engineers, medical doctors, technologists, educators associated with nuclear and allied disciplines. PNS is 32 years old, registered society. Main objective of PNS formation was to promote peaceful uses of nuclear technology in various sectors, including health, agriculture, environment, power generation, water resource management, industries, and much more. More than 2,500 people are PNS registered members, including more than 1,200 lifetime members. PNS has more than 1,100 associate members of 70 professional colleges and universities of Pakistan. PNS has fellows, expert pools, and visiting faculty. PNS has 2 women in nuclear and youth in nuclear chapters. It is an honor for PNS that 8 lifetime members are recipient of highest civil award of Nishan-e-Imtiaz. And more than 50 members are recipient of the other civil awards like Hilal-e-Imtiaz, Sitare-e-Imtiaz, Pride of Performance, Tamga-e-Imtiaz, and President Gold Medal. Now, the technological manpower can play an important role to resolve challenges of technology development in Pakistan. Their experiences may be used for capacity building in science and technology in the country. All activities of PNS cover peaceful application of nuclear technology and focus on transferring knowledge about application of nuclear technology in daily life. PNS is helping to create awareness and building an environment in public to develop interest in younger generation in the field of nuclear science and technology. To achieve its aim, PNS conducts conferences, seminars, webinars, lectures in different forums. I welcome all you to become lifetime members of PNS and contribute in nuclear field for socio-economic development of Pakistan. In concluding my remarks, I would like to thank all of you once again for your engagement. Thanks.
Thank you very much, sir. Now I would request Professor Dr. Khurshid Hasnain, who is the advisor of comstech, for his vote of thanks.
My work has been made easy because the speakers before me have already thanked many of the people and organizations who have been involved in the organization of this activity. But still, representing comstech, it's my duty to once again thank all those people and some of those who haven't yet been mentioned. Particularly, let's start with all the resource persons who gave us their valuable time, who came from different cities, and indeed, of course, to both of our honored and our guests from Bangladesh and from Kuwait. We know how difficult it is to find time to go to another country, and you've done so, and thank you particularly for giving us this opportunity. And of course, your knowledge and your experiences have enlightened this audience. And I refer to all the resource persons who, of course, have vast experience behind them of this field. And I just can hope that this will lead to increased cooperation, interaction between you, and more productive activities coming out of this workshop. I thank all those who took part as chairs of the sessions and conducted the sessions, all members of the organizing and technical committees, and in particular, I want to mention Dr. Mohammad Tahir Khaliq, the president of Pakistan Hindu Society, Mr. Waqar Ahmad Butt, the vice president of the PNS, who in fact started the discussion with us on organizing this activity, and of course, Dr. Shazia Fatma, who has done a tremendous amount of work in arranging the speakers and technical program of this committee. I especially thank you for your efforts. Maybe you do not know, but the entire administration of Comstech is involved to a large extent in arranging these activities, because we have to board and lodge our guests and arrange for transportation, etc. So I want to thank again all of my colleagues at Comstech, all the administration who took part in arranging the logistics, the hospitality, the boarding and lodging needs of our residents, and the staff involved in our dining and transportation, the guest house. They have to spend extra hours to take care of you, and so I think they deserve a round of applause. The IT staff who arrange for all the online registrations, the online participation, and web links, they also have to be completely involved. Our media section, Mr. Shabir Hussain and Mr. Ikram, for providing excellent coverage of the event. Maybe you have not seen it, but it is there in the electronic media as well. Thanks to them. Then I have Mr. Umar Ali, who works with me, and thank him for coordinating various aspects and various needs of this event. Ms. Khadima Muazzam, who's handling the stage. But last but not the least, I have to acknowledge once again, as always, Mr. Muhammad Jamil, whose efforts, he managed all the announcements, registrations, correspondences, secretarial duties. In fact, half the work of this conference was done by Jamil. So let's give him a big hand. Well, most of all, I would like to thank all of you, the audience who participated from the start to the end. It is very gratifying to see you in such numbers and continuing to express your interest in the proceedings as exhibited by your questions and your interaction with the resource persons. So thank you very much for being a part of this. Without you, the activity, of course, has no meaning. Only a couple of things I just want to say, besides the thank, that is, it is our effort that all these activities should not only be Pakistan-oriented, but be as much possible OIC-oriented. So what I would request the PNS and the PSNM both, that if we can somehow arrange for the proceedings of this workshop, and we could document it, then we could share it with our other partner states and organizations, which could then lead to a larger conference, actually, maybe not necessarily in Pakistan, but of course involving Pakistani scientists. So think about this. If the proceedings of this activity are prepared, I'm sure we will have a case to go on towards having an OIC conference of nuclear medicine. So think about it, and we are of course here to whenever you wish in our offices here in Secretariat, and it would be great to. Finally, just one word about something new which I was also able to comprehend more than I could comprehend the medical part. That is the use of the AI in nuclear medicine. I just wanted to share with you that the OIC itself and various bodies are very keen on the promotion of AI in areas which deal with the essentials like, health and medicine, other things like food security or other areas like education, in fact, even urban. So it would again, I look forward to interacting with those scientists who talked about the AI. Maybe we can get some idea about suggesting some activities on the AI related to medicine and health. So with that, I think I have covered all the ground that I wish to cover. And thank you all once again. And we come to the end of this activity. Thank you.
Thank you very much, sir. Now we will move towards distribution of shield and certificates to our foreign speakers and local resource persons. To do the honor, I would request Professor Dr. Khurshid Hasnain, Professor Dr. Tahir Khalik, and Dr. Shazia Fatma to please join in front of the stage. At first, we will be giving out shields and certificate to our foreign OIC speakers. Professor Dr. Rehan Hussain from Bangladesh. Sir. Professor Dr. Abdul Hamid Al-Ghazar, who is here with us from Kuwait. Now for our local speakers, we have certificate. First of all, we have Dr. Shazia Fatma. Dr. Muhammad Adnan Saeed. Dr. Muhammad Babar Imran. He's not here with us. So we have Dr. Arzu Fatma next. Brigadier Mahdi Raza. Dr. Ahmed Hassan Nawaz. Ms. Noreen Marwat. Do we have Ms. Noreen Marwat? No? Dr. Nadeem Ahmed Lodi. Dr. Zahir Chirag. Thank you very much, ladies and gentlemen, and all the participants. They can collect their certificates. The male participants can can pick up their certificates from the registration desk, whereas the female participants can collect their certificate in this auditorium. And with this, thank you very much for joining us. Please join us for the tea outside this auditorium. Thank you very much.